ready, sir. In the order, they are ready to go. Yeah, first 4 speakers.
Okay, great. And in the meantime, please call the third set also, Deva.
Yes, sir. I've done
Vasan.
that. I've done that. The fourth set is
Okay,
ready.
great.
Third one person is ready. I've called the other person.
Please. We are live, please.
Okay, good evening. So good evening, all the AIS members and the members and the executives of YOSI as well. Let me take this opportunity to welcome all of you. Today's webinar is going to be an unique combination, and that's why we call it a synergy of the exuberance of youth and the wisdom of AIS ARC. So we will be seeing a different type of a webinar. We will be having debates as well. So in this year, since the January, we have started associating with various subspecialty societies, and this is our first association with YOSI, and today's webinar will be unique, as I already suggested. So welcome every one of you, all the speakers, all the panelists for being with us and preparing well. I'm sure you are going to do a great job. And without much ado, can I request President of YOSI, Dr. Divakan Mishra, to have few forward, and after that, the moderators can take over.
Thank you so much, Prashant sir, and it's indeed an honor to collaborate with ARC on this wonderful and amazing concept. And thanks to Dr. Adityan and Dr. Prasanna for brainstorming over this. I would like to thank all the ARC members, Srinivas sir, Anaga ma'am, Dr. Deepak sir, Kasturi ma'am, Dr. Tinku Bali ma'am, under the leadership of Prashant sir, for giving us this opportunity. Look forward to this entertaining and yet a great learning session for us.
Okay, so I think Deepak and Srinivas, please go ahead.
Thank you, sir. Now we are going to start our debate. And the first debate is, you can say anything, man versus machine, or hand scale versus the machine scale. But the best term and the most popular one is SICS versus the Phaco. And without any delay, I would going to invite our first speaker and our co-moderator, Dr. Prasanna. Dr. Prasanna, please. He will be going to defend SICS, and Dr. Ritu Singh will be going to defend Phaco.
Deepak Srinivas, please welcome all the chairpersons, co-chairpersons. Hello, Deepak.
Would you want me to do so?
Yes, sir.
Yeah, either of you, please go ahead.
Our chairperson today,
yes,
for this innovative webinar, which is going to talk about hot debates on old problems and new solutions, we have Dr. Kasturi Bhattacharjee, Dr. Prashant Bhavankule. We have our very own Dr. Divakant, Dr. Nilesh, who's the secretary of YOSI. Our co-chairpersons today are Dr. Anuga Harur, Dr. Tinku Bali, Dr. Sonal Kalia, who's our ex-president of YOSI, and Dr. Karan Bhatia, who's the vice president of YOSI. Our moderators today are Dr. Deepak Mishra, Dr. Srinivas Joshi, me, myself, Dr. Aditya, and Dr. Prasanna. And with that, I think we can open the innings and have the first hot debate on the Phaco conundrum, SICS versus Phaco. And our discussant for this talk would be Dr. Anaga ma'am. And our first speaker is Dr. Niranjan Karthik, who's going to talk about SICS, and our very own Dr. Ritu Singh is going to talk about phacoemulsification being the right option. So over to both of you, and I hope we have a very hot and nice debate happening right now.
Thank you, Aditya sir. Thank you so much. So I'll be shortly sharing my screen as well. I hope my screen is visible. At the outset, I would like to thank AOS ARC, Prashant sir, and all the experts from ARC for giving us this opportunity. And our dear YOSI Governing Council again for bringing together this wonderful debate and letting me be a part of it. So I'm here to defend in the short period of 4 minutes as to why SICS is here to stay and in fact continue to rule, I would say, from the EO perspective. And let's get ahead. So I would like to keep forth my standpoints in these broad categories as to, for the surgeon, how is it better, for the hospital and for the patient. So let us go ahead. So us being ophthalmic surgeons, it is a procedure that is quite familiar to us from the word go. In our post-graduation days, we are more accustomed and exposed, I would say, to manual SICS. And only in the later parts of our training process are we exposed to this advanced procedure of phaco. And secondly, this phacoemulsification is not made available widely to all the postgraduates in training unanimously across the country. So this is a procedure that's quite popular in the starting phases of anybody's career to begin with. Now I have some excerpts from various papers which have thoroughly scrutinized and compared these two procedures. And I have here a collection of points to stand and speak for me. So first, what everybody is quite concerned about is the visual outcome. So this is a paper by Parikshit Gogate sir, and these are small snippets right out of the paper. And here, what we see is that both groups are quite similar and in outcomes, and especially with when you're talking about a visual acuity of more than 6/18, around 98.4% in both phacoemulsification and small incision cataract surgery. And secondly, the point that they have stressed is that the success in both techniques is more or less surgeon dependent, and reducing the size of the incision did not technically lower the astigmatism, and hence the levels of astigmatism was not too different. And there were better outcomes in more complicated and tougher situations like white cataract, which of course we'll be discussing. Coming to the duration of surgery, unless one's experienced in phacoemulsification ended up taking longer than manual incision cataract surgery. So for the surgeon, it has special roles in complex situations like white cataracts. In a country like India, which is still developing in many ways, or more often than not, they present quite late in an advanced stage, where again SICS has an upper hand. And phaco associated with higher energy needs and increased risk of PCR and wound burns in such complicated white cataracts, which are quite advanced. While SICS, there is not much energy used and relatively lesser intra-op complications, as again backed by this paper. Some inflammatory scenarios like Fuchs iridocyclitis, again, SICS has proven to surpass phaco in both having lower duration and being possible to be done in low resource settings as well. And they've proved that it's an effective and an efficient technique for subcontinent countries with limited access to phaco. Now, coming to the hospital perspective, the colossal cost of maintaining and phacoemulsification with its AMC, that is annual maintenance contract, has been very beautifully explained by, again, this paper by Gogate sir, which has really given a very precise comparison in both Indian rupees and the US dollars. And they have also mentioned about the additional cost per procedure for the use of phacoemulsification, which was done in 2005. And at that time itself, it was about rupees 271 extra. Not only that, now considering the cost of medical inflation, this must have at least twice, become double or at least 3 times what it was at that time. And the use of consumables, the cost that entails it, again, was much higher for phacoemulsification compared to manual SICS. Now, for a hospital which has to cater to large volumes, especially in low resource settings like camp settings, SICS definitely has an upper hand, which is less dependent on machinery and more on the skills of the surgeon, and the equipments required are of much less sophistications. Of course, it is proven that the surgeries, like I mentioned, unless one's experienced with phacoemulsification, it is definitely faster to consider SICS. Now, coming from the patient perspective, definitely affordability plays a crucial role for a common man. And again, this paper has gone a long way in proving that phacoemulsification is definitely more expensive than SICS, with a very cost-risk comparison analysis. And this again stands to favor my point. So the take-home message would be from a novice surgeon perspective, which is who we are, the young ophthalmologist, starting out his or her practice or surgical career, especially in complicated situations like mature cataract, which is not an uncommon scenario in a developing country like India. SICS provides decent outcomes at affordable cost to both the patient and the hospital. These were my arguments for the day. Thank you, and looking forward to the counter arguments.
Now, the other side of the ring, Dr. Ritu,
Thank you.
Sir, please go ahead.
Yeah. Thank you, Dr. Niranjan. Now, yeah, Dr. Ritu, please.
A very good evening to one and all. And yes, I am the counter argument person here, speaking on the cataract conundrum, SICS versus Phaco, who's friend and who's the foe. I won't go into the details of the theoretical stuff that we all are aware about. I'll directly jump to the crisp points. The initial steps of the cataract surgery in both SICS and Phaco are similar, except for the CCC, which is precise and smaller in our phacoemulsification. And if there's someone who is more into precise stuffs, they carry about femto laser assisted cataract surgery. I perform only manual phaco, so I would be discussing about that. First and foremost, there is no need of the brittle suture, therefore omitting complications such as muscle or soft tissue damage or any inadvertent globe perforation. The incisions given are clear. Therefore, they are smaller in size, somewhere around 2.8 to 3.2, and micro incisions cataract surgery are less than 2 millimeters also. The surgery is almost bloodless and devoid of pain because we give clear corneal incisions, and all the sequelae due to poor tunnel construction are also avoided in phacoemulsification. Since it's a closed chamber procedure, there are less risk of expulsive hemorrhage or iridodialysis-like complications. The surgeon has a more the surgeon has more control over his maneuvers, and all the phacoemulsification nucleofractus techniques are performed inside the bag, therefore away from endothelium, thus keeping it safe. Further, next steps would be including the IA part. It's better done in phacoemulsification as the surgeon has a choice of coaxial and bimanual IA, and we also can polish the capsule, which is not really that easily done by the Simcoe. We have foldable IOLs. We have foldable IOLs implanted via phacoemulsification incision that have a range from monofocal to multi and toric, which no SICS surgery offers. Last and not the least, it's a sutureless technique. The patient is happier, has a faster visual recovery, and less surgically induced astigmatism. We say that if there's no pain, there's no gain, and it stands true for the gym buddies, but phacoemulsification can be carried out also in topical anesthesia. We don't need to give pain to the patient. And if there's any patient who's quite lazy and hasn't put any dilator drops preoperatively, here's a paper published by my thesis guide, which is on preoperative topical mydriatics. Also, phacoemulsification can be clubbed with different surgeries. Therefore, it's a friend indeed. Patients after the surgery are, as this meme shows, happier because it's a daycare surgery and the patient is sent home on the same day. And sometimes the SICS patient is asked to stay back in the ward, maybe for 3 to 4 hours. A patch is also provided as a gift. So that's something that SICS and Phaco differ in the surgical outcomes. I move a little deroute from the topic here because I need to highlight that we have a great cataract backlog in our country, and both the surgeries give endothelial damage as a side effect. So it now brings a question that why is Phaco always highlighted that it is not quite the option for hard nuclear cataracts? I had a paper published in IGO which was studied only on hard nuclear cataracts, and RCT that was between phacoemulsification and manual small incision cataract surgery. I'm going to skip the inclusion and exclusion criteria. It followed the consort guidelines here. The stats revealed that there was a difference in the endothelial cell density compared to the pre and post 6 weeks in both the cases, and was statistically significant in the Phaco group indeed. But there was not a significant difference in the central corneal thickness. That means, although there was a functional damage to the endothelium, it didn't cause any anatomical difference because the hexagonal cells anyway have polymegathism and pleomorphism, all of these pathology all of the ways to counterattack their damage. These are the These are the factors which were statistically significant in the phacoemulsification group: age, cataract grade, the effective phacoemulsification time, and the anterior chamber depth. Interestingly, anterior chamber depth was also statistically significant in the SICS group. So basically, the culprit is not phaco, it's the shallower ACD, which causes the damage to the endothelium. On plotting an ROC curve, the receiver operator curve, we found a cutoff value of 2.86 millimeters, which was where we can decide which surgeries to be performed in the hard nuclear cataracts. So the famous Salman Khan ka Gana "Main karu to sala character dhila hai," that doesn't stand true for phacoemulsification. It really isn't the culprit. There are a few Oriental countries, South Asian countries, which have published that the axial length is directly proportional to the anterior chamber depth, but this was not the case in our population. It was a non-parametric data. So again, we need a greater amount of sample size to bring that into discussion. Over nearly 2 to 3 decades, there have been various studies analyzing the ECD loss with the CCT, and all of them keep saying that the endothelial cell density loss is almost equal in both the groups. And the last, which I have highlighted here, CONGSAP in 2019 said that the post-operative CCT was greater in the phaco group, but it wasn't so on our study. I would like to end the talk here that SICS indeed is an art, as Deepak sir also said, but phaco fulfills the newer advances and the needs of the surgeon. For example, flax has come upon, you can do MIGS and vitrectomy with it. Even harder cataracts are being performed using MyLoop. It's a promising modality, and therefore it is right now the present and also the future of cataract surgery. But in this tug of war, nobody wins. It's the surgeon who's the awesome one here. So if you're great at SICS, you're amazing. If you're great at phaco, you're super amazing again. Thank you so much, everyone.
Wonderful, Ritu. As you yourself said that it is nothing to win or anyone win or anyone lose it. Only thing is that both are a different mode of the surgeries. We can clearly know that either SICS or phaco, both having some advantages and disadvantages over each other. But again, both you and Niranjan done justice with the topic as per my commentary is concerned. Devakant, you want to say anything?
Yes, sir. So these days, sustainability has become a big issue, especially in the Western countries. So SICS has a little edge over that when we talk about sustainability, saving costs, and these things. But again, this is a wonderful technique, phacoemulsification, and that's the go-to procedure these days. But I think the bottom line is SICS has a space still, especially in countries like India, Africa, and all these.
Ritu, stop sharing.
And even in the Western countries where they want to be more sustainable with their surgeries. So great talk and very nice inputs from both these people.
Anaga is supposed to have the
discussant
final word.
Anaga madam.
Yes,
Please.
yes. Absolutely fantastic talks by
Thank
both. So see, basically it is not just one against the other. We should know both the procedures. Even the beginners should know how to do phaco, and the experts also should know how to do SICS. Which to use at what point of time depends on a lot of variable factors, right? From what is the grade of cataract, what are the other features, like what is the corneal endothelial condition, whether there is any corneal guttata, the size of the pupil, whether there's pseudoexfoliation, whether there's subluxation, so many other factors. It's may not just anterior chamber depth, not just axial length. It also depends on what kind of phaco machine you are using. So you can have a soft cataract done by a phaco procedure and still have corneal endothelial cell damage. You can have corneal edema just because the procedure was not done in the right way. At the same time, you can have a hard nuclear cataract done by SICS and 6 vision the next day. So which technique to do, how, at what point of time, how to explain to the patient, and also you need to counsel to the patient what he is in for. If there is a patient whom you think you might need to convert, you need to also explain to the patient that yes, we'll go ahead with this, but we might need to convert to an SICS. So there is no ego issue in converting to an SICS if it is going to do good to the patient. Most importantly, do no harm is what I think we should focus on.
The past secretary of
Thank you.
ISMICS, Srinivas.
See, being in a difficult position, I feel I echo with the speakers and the panelists. In terms, I wanted to say that in my next talk, do good what is best in your hands. If Phaco is best in your hands, please do that. If you feel that SICS is best in your hands, please do that. I think there should not be much of debate or controversy on this because it's been an age-old topic and the debate is still going on and on and on this topic. I think the only thing I would like to say is, as Anaga Madam rightly said it, do good what is best for your patient. Thank you very much.
Can I ask the
Very
opinion of
true.
all the ARC members? See, if there are initial steps for a young people is to learn through SICS, so shouldn't they try to upgrade into an Phaco? If you say that you are comfortable with ISMIC, with the SICS, should you not upgrade?
Of course.
Okay.
Of course we
So
should.
just to answer this question, Prashant sir, in the Western countries, the residents first learn through Phaco. So what is given to you, they learn with that. We were first given to do how to do the capsulotomy and then given the capsulorhexis, which became more difficult. First, always learn the difficult part because there was no other choice for them in the Western countries. They were first made to learn with the Phacos itself. In India, it's a different school of thought. We learn with the SICS, we learn with the ECC, and then evolve into the Phaco. But as far as learning is concerned, I think they should not be, because how the Westerners are doing then? How the Western students, the PG1, although they have 5 years, the PG1, PG2, they are doing fantastic Phacos by PG2, PG3, where they don't know any other technique, including ECC, is just to extend and bring something out. But otherwise, they start with the Phaco itself. Just my thought. Others can give your inputs, please. Anaga madam, you had wanted to tell
Yes,
something. Sorry.
no, I feel that yes, everybody should know how to do everything. In fact, when we were residents, we were not taught Phaco at all. Neither were we taught SICS. So we learned it along the way. So basically, you need to learn all the various techniques. Phaco is something which you have to learn because that gives you the advantage of a very small incision. At the same time, in certain cases, when you have to do SICS, you should be ready to do that.
So the challenge I feel is that every new technique which comes, you should learn to get out of your comfort zone. Even if you have learned SICS and you're master and you're comfortable, you should learn, but in a stepped pattern. Do not do the simpler cases whenever you graduate to a next technique, be it from SICS to Phaco or Phaco to SICS, either way, wherever you have learned like. So graduating and getting yourself out of comfort zone in today's era is equally important rather than just looking at your own comfort zone. But yes, of course, with a writer that you should be taking care of the patient and you should not harm him. Next debate, I believe.
Thank you, sir. Our next debate is just what to do if there is no lens implant. Means we are going to plan for a secondary IOL. Then we have two most common options. Either we go for the SF IOLs or the iris claw. So for our next battle, Dr. Aishwarya, you are ready?
Yes, sir.
Dr. Aishwarya will start her talk on SF IOL.
Sir, iris claw IOLs.
Iris claw. Yes.
My screen is visible, sir?
Yeah.
Yes, yes.
So good evening, everyone. Thank you for the opportunity for presenting tonight. We had a very interesting discussion about putting SICS or Phaco as the primary surgery. But when we do not have the physiological bag and we have to manage aphakias, the capsular support is must when it comes to putting secondary IOLs in sulcus. Now, when there is not sufficient capsular support, there are two main IOLs that are present, iris claw IOLs and scleral fixated lenses. I'll be speaking for iris claw IOLs because one, it is a safe, predictable and an effective procedure as was shown as early as 2005 in Journal of Cataract and Refractive Surgery, where they showed that IOL implantation by iris claw method is effective and predictable when it comes to aphakia management. Secondly, there are multiple advantages of iris glow IOLs over scleral fixated lenses. Let's discuss them one after another. First being shorter surgical time. This paper in 2011 in GRS published showed that the mean surgical time of iris glow implantation was significantly shorter than that done by scleral fixated lenses. Shorter surgery means less risk of photic damage as well as lesser complications associated with longer surgeries. Also, the learning curve is less and the technique is easier. Thus, when a surgery gets finished earlier, it leads to early visual recovery and a reduced risk of post-operative increase in the intraocular pressure. As I said in my title, there are no strings attached as far as the newer generation iris glow lenses are concerned. So there are no sutures. No sutures, that means no suture-related complications. The erosion of suture or the exposure of the suture, the breakage and thus leading to dislocation of the suture, and the fact that the haptic is being extruded from the inner part or the intraocular part to the extraocular part leads to higher invasiveness in scleral fixated lenses, thus leading to a potential and a theoretical increased risk of endophthalmitis. You can see here that the majority of the group of complications of SFIL either belong to the haptic or the suture category, which are completely avoided in iris glow lenses. IOL tilt is another important complication in scleral fixated lenses, almost as high as 10%. And you can see in the study here that 1 mm of tilt can lead to almost 15 degrees of astigmatism. It can also, a patient presented to us, and you can see here that because the IOL was touching the iris, it led to pigment dispersion, recurrent hyphae which the patient presented with, and it can also lead to secondary glaucoma. Now, IOL dislocation, although it seems that it would be commoner in iris glow lenses, studies have proven, and not just one, but multiple studies have proven that the dislocation of posterior as well as anterior fixated iris glow IOLs is lower than that by the suture breakage or other causes in scleral fixated lenses, which can go up to as high as 28%. You can see here in the clinical picture of an almost dislocated lens about to go down, and you can see the UBM picture of the same. The endothelial cell loss, as shown by this paper by Dermas et al. In a BioGlue Eye Journal in 2023, that the implantation resulted in a significantly more endothelial cell loss of a scleral fixated lens when compared to the iris glow lenses. Although there is a meta-analysis which compared anterior chamber lenses, scleral fixated lenses, and iris glow lenses, and the endothelial cell loss by all of them, it showed that there was no statistically significant difference in either of the three groups. But the majority of the studies that they had taken had anterior fixated iris claws, but the retrofixated iris claw present, the retrofixated iris claw, the retropupillary iris claws have a lower endothelial cell loss as proven by two papers recently published, one by us. It is more physiological, although it comes at a slightly higher disadvantage of a higher risk of dislocation. Now, Bading and Vogt in this original article published in 2012 showed that the choroidal hemorrhage and the retinal attachment rate is as high as almost 8% and vitreous hemorrhage going up to 13%. This is the case in which there was vitreous hemorrhage intraoperatively, which led to a poor glow and red glow, because of which the surgery became difficult thereafter. People claim that the iris gets damaged once you put an iris glow IOL, but this review published in 2001 showed that the IOLs are fixed to the mid-peripheral portion of the iris and therefore do not interfere with the normal physiology of either the iris or the angle structures. You can see in the clinical picture that there is no ovalization and there is a very circular normal pupil that is there, and the normal pupillary dilation and constriction remains constant even after putting the IOL. Pupillary distortion or the horizontal ovalization of the pupil, although present in early postoperative period, is only temporary. It's not permanent, as was published in this paper. This is one of my own cases which showed that almost up to around 3 months postoperatively, you can see that the pupil dilated completely, and a complete dilated fundus examination could be done without any risk of missing the ora or any peripheral lattices or changes. In cases of megalocornea, as was this case report that was published, since the exteriorization of the haptics become difficult because the cornea itself is 13 mm, and if you go 1.5 to 2 mm beyond it, the little or no part of the haptic can be extruded. So in such cases, iris glow becomes the only option, iris glow and ACIOLs. In cases when there is scleral thinning or marfans or ophthalmic cases where you know that the haptic extrusion is very common, iris glow IOL can come to your rescue and can be put safely in these eyes. Although one may claim that in cases of damaged iris or iris colobomas, one cannot put iris claw IOLs, apart from the rare exception of aniridia, in cases where 180-degree iris is present, you can put iris claw lenses. In cases where there is no significant iris, you can first do a pupilloplasty and then put an iris claw IOL. In cases of coloboma, we have successfully implanted multiple in different patients. If there is an increased risk of pseudophacodonesis, you can not only put 2-claw IOL, but you can put a 4-claw IOL that will increase its stability and reduce the donesis of the lens. So to conclude, in cases where there is no capsular support, a safe, simple, and a short procedure that in cases of Indian lenses is also cost effective is the iris claw lenses. So much so that the iWiki American Academy of Ophthalmology said that in cases where there is no intact anterior capsule and there is a sufficient iris tissue, you should go ahead with iris fixated IOL. And if there isn't sufficient iris tissue, you should first do a pupilloplasty and then plan an iris fixated IOL. And in cases when none of them are present, then only you resort to scleral fixated lenses. Thank you so much.
Great side of your debate. Now over to, can you stop sharing, Dr. Aishwarya?
Sure.
So over to the other Dr. Ritu today, who's going to talk about SFIOL being an option right here. So over to you, Dr. Ritika.
Yeah, trying to share my screen. Is my screen visible?
No.
No.
Oh. I don't know, some.
I'm still not visible.
Yeah, I don't know, there is some problem. I'm so sorry. I don't know what's wrong with my file. It's not showing that option only.
Often happens when you have suddenly aphakia during cataract surgery.
Doctor, can you try again, please?
Sunil, can you just help? Have you opened your file?
Yeah, it is open on the other this thing on my Mac.
Dr. Ritika, did you join from browser rather than application?
No, it's from the application only.
You should have a button on the bottom which says share.
Yeah, I'm doing that, but it is not showing my presentation.
Just try again, please, once.
In the meantime, I'd like to ask the panelists, the chair people, what are your choice of correcting aphakia? I know Dr. Bhavinkule will say SFIOL. Just
Dr. Ritika, any luck?
No, it's not coming, sir.
Let's not influence the choice. We can have a
green
discussion on something else. Otherwise, the debate will become a.
Ask the third umpire.
Dr. Ritika,
you can share the entire screen. You can try sharing the entire screen rather than presentation.
The option only is not coming somehow today in this.
Can you just can you just log out and log in? And please join from application. I think you've joined from browser. If the option is not coming, that means you're joining from browser.
No, I've joined from the application. This application.
Just try logging out and logging in once. We can.
We move to the next debate. Meanwhile,
Yes.
I think Srinivas.
Sir, a small change in order, sir.
Yeah.
We'll move to fourth set now, sir, because there is one speaker missing in the third set.
No issues.
Yes,
So
sir.
let's move.
Prasanna, is the Karthikeya there?
So Karthikeya Singh is not there. Only Samir is there. He's joining in a bit. So shall we move to the third set?
Please go ahead.
Yes. Move to the next one, Prasanna.
Yes, sir. So next we have moving on from cataract to squint. We have Dr. Gunjan Saluja and Dr. Shruti to talk on muscle plication versus muscle resection. So Dr. Gunjan has shared a presentation. She's here for the debate and answering questions. So it's going to be a recorded one. So Dr. Gunjan's talk will be first on muscle plication.
Meanwhile, can we request her presentation to be shared with one of you so that in event if she fails to do it for the first debate, Dr. Shruti, we can have it?
Ritika, please.
Sure, sir.
Yeah? Okay.
Thank you, sir. I'm just playing Dr. Gunjan's presentation.
A very good evening, everyone. First of all, I would like to thank YOSI for giving me this opportunity. I'll be talking about the muscle strengthening procedure, plication. So resection is the conventionally performed muscle strengthening procedure. This involves shortening of muscle and removal of muscle stump, making this surgery irreversible and compromising the anterior ciliary vessels. Hence, the surgery is not preferred in patients requiring more than 2 muscle surgery. Plication was initially described in 1983. The classic tucking involves muscle-to-muscle union that can loosen up with time. And that is the reason why this procedure lost its importance. Wright reintroduced the procedure as muscle-to-sclera union. Mini plication was also described that involves folding of central 3 to 4 millimeters of the muscle for small angle strabismus. As plication is a simple procedure, it can even be performed through these small incisions. In this procedure, we can see that a fornix-based incision is maced and muscle is hooked. Sutures are passed at the desired measurement. Sutures are then passed through the sclera, and once they are passed through the sclera, they are passed back again through the muscle. This makes a muscle-sclera muscle union, reducing the chances of loosening. Sutures are then tied and muscle folds upon itself. In case if the muscle is loose or it hangs back, the suture can be passed through muscle and sclera and tied. Comparing resection and resection plication, we can see that both the procedures have almost equivalent results in these patients. At 1 week, these 2 patients had similar surgeries and they had similar kind of squint. And we can see at 1 week post-op, both of them, they had equivalent amount of redness. Though a small lump can be seen in the plication patient, but that disappears usually in 4 to 6 weeks. Coming to the literature, several studies have been done comparing resection, and resection plication procedures, and all the studies have concluded convenient and predictable effectiveness of plication, and it was found to be equivalent to resection. Coming to advantages of plication, it is a simple surgery which has a short operating time. There's less surgical trauma, inflammation, and hemorrhage. It can be performed through a small incision also. There's reduced risk of lost muscle. It reserves the anterior segment circulation. In the early stages, that is at around 1 to 2 weeks, you can easily reverse the procedure also. The recovery is easy and cosmetic concerns like elevated conjunctiva, visible lump are all self-limiting and usually, as I said, disappear at around 4 to 6 weeks. Hence, to conclude, horizontal or vertical muscle plications are safe and effective alternative to resection along with recession procedures. Thank you.
I think we should congratulate Dr. Gunjan. She has been conferred FRCS in this week only, or what, Gunjan?
Yes, sir. Yes, sir. Good evening, sir. I'm still actually outside traveling. So that's why I had to give my presentation recorded. Thank you, sir.
We would all congratulate on behalf of IRC as well as
Congratulations.
Thank you, sir.
Congrats, ma'am.
Thank you.
Okay, let's move on.
Yes, sir. With that, we'll move to the counteracting squinting partner, Dr. Shruti Nisha. Over to her for the resection topic.
Yeah, congrats to Dr. Gunjan. So though I agree with her on the FRCS and congratulate her, I do not agree with her on the plication. So I'm going to be counteracting my arguments with resection being still the standard of care. So whenever I was given this topic by Dr. Prasanna, thanks to you and YOSI and ARC for this opportunity, the first thing that struck me was that muscle resection is like poor Batman. He always goes on to become the villain because he lives long enough without dying a hero. So muscle resection has been around for dog number of years. It has proven its efficacy. It has been a hero in all forms of surgeries. And yet today we stand here with this question. So let us understand resection that came in way back at 1849 when Guerin performed muscular advancement. By 1883, the pleating, the bringing forward technique was brought, and then it was regularized by Blaskowitz. So by the end of 19th century, resection by itself was the norm and was a standard of care for strengthening the muscle. Well, if you think that, resection is an old procedure and that's why it's been on for so long and people don't want to change, well, we'll be surprised that plication is as old a procedure as that, and it was described as early as 1883, but it never caught on because it was always muscle to muscle, and muscle to muscles don't kind of take up too well. It was only back in 1991 where Kenneth Wright spoke about muscle to sclera attachment, and that's when the actual thing got caught up. So, if we think plication is a relatively new procedure, of course it's not. It's been around quite a while, but still resection has stuck out as the standard of care. Now, I know my valuable worthy opponent would be talking about equal efficacy and less trauma. Now, though many studies talk about equal efficacy, when we look at practical experience, including mine, and the one from the famous Hunter group also, they spoke about reduced surgical success rate of the plication compared to the resection. And this was way back in 2017 when plication was really catching up. So really, there's not much of results that talk about plication not being as good as resection, probably because the publications aren't enough. And for the question of less traumatic, a beautifully done resection actually is very, very less traumatic. So it's really in the skillful surgeon's hand as well. The second point that my valuable opponent would bring probably is it's reversible. But really, is it truly reversible? Well, it's reversible only in the short term, which means that within the first 4 weeks, if you really tend to do something, you have. Otherwise, you can see this nice bump out here, and that's where the fibroconnective tissue formation happens between the muscle layers, and then it becomes kind of permanent. So again, it's not truly reversible in that sense. Okay, the next point that my opponent would bring about is its vessel sparing. Well, really, is it relevant considering that the incidence of anterior segment ischemia after strabismus surgery was just 1 in 13,000 or 1 in 30,000. I've seen even much more senior strabismus surgeons perform around 30,000 as their entire lifetime cases. So we're looking at very rare incidences of ASI. And do we need to actually change procedure, just even if it's a simple 2-muscle surgery, to something as, as dramatic as ASI? And of course, the factor of safety and so-called slipped or lost muscle. Again, the incidence is just 1 in 5,000 and not even in healthy muscles. It's barely in tight muscles and restrictive muscles. So if in healthy muscles, we really don't need to be worrying about all of that. Now, let's talk about the stuff that they actually don't talk about in plication. And the number one is the bunching of the conjunctiva. Well, if you have a young person coming in for a cosmetic squint and you give them a bunched up conjunctiva, bunching of the muscle in the initial postoperative period, they're not going to be happy. So move over the pregnancy bump. We now have a new bump, and that bump is because of the plications that we see immediately postoperative, quite cosmetically unacceptable. And I think just because of that, it may not be a very recommended procedure for all. And when it comes to results, they're quite variable in different hands. And that's probably because the techniques vary a lot. There's a muscle to muscle, there's muscle to sclera, there's the figure of 8, there is going back and coming back, there's bunching up, there's bunching out. There are just so many procedures that are available within this same technique itself. The next thing is, are the results really predictable? Well, again, this was a systematic review with a meta-analysis that compared plication versus resection in horizontal strabismus surgery. And they found that the amount of exodrift was not predictable with plications. And many physicians actually planned to change their surgical doses and overcorrect in the early postoperative period, especially in plications. Again, the data for long-term is really, really missing in plications. And that's the white elephant that we need to address. Name that study, and the study has not gone on for a follow-up of more than 12 months or 18 months. The longest study that has come out recently is one from from South Korea, and this was published in BMJ. And here you can clearly see this was a 2-year follow-up, barely a 2-year follow-up, and you can see the surgical success at postoperative year 2 was 53.5% in the RR, which is the recess resect group, versus 27.8% in the recess and plicate group. So again, the recessed plicate group had much lesser surgical success in the long run as compared to recessed resect procedures. Again, you can't do upshifts or downshifts, or you can't transpose these muscles once you're going to plan to do applications. You cannot do these procedures in large angle strabismus because there again, you want to have good resection effect. And if you're planning to do muscle transplantations, again, you cannot do plications. Again, there you'll have a problem. So if you ask me, and this is my last slide, plication is just another option of armamentarium in the muscle strengthening segment. And it can be only recommended in special situations like more than 2 muscles in one eye or eyes with trauma or any form of compromise. So even in these 2 conditions, the resection, our own Batman will shine out the bat signal, and then probably Robin can actually come to help. So maybe plication can help resection, but Robin can never become Batman, and only time can tell if plication can truly replace resection. Thank you so much.
I think very well put from both sides. And I think
Dr. Aditya, I would like to add one thing. See, first thing, my colleague said that, it's not reversible. It is reversible for 4 weeks. At least it is providing a window period for 4 weeks for the patient. Secondly, the bump, as I addressed in my talk also, it usually disappears in 4 to 6 weeks. Third thing, vessel sparing becomes important sometimes when you have vertical squints also. Like in patients with monocular elevation deficit, when you are planning naps along with an IR recession. So how can this be possible? Third thing is when you are having a DVD along with a large angle esotropia. So then you have to go for an IR plication. You cannot go for all the 3 muscles in the same setting. Then the fourth thing for the large angle strabismus, as I had shown in my presentation also, the patients that I had operated, they all had large angle squint, and there was a comparison that I showed at 1 week. So the redness and everything, it is almost the same. It's just like, I'm not saying resection is not good because I equally perform both the procedures, but it is an equally viable option. Definitely the muscle slip, the complication of muscle slip is not there. And you being a strabismus surgeon, I think very well know how the muscle slip patients present and can be a nightmare to a strabismologist at times.
So Gunjan, it's a more, let's not have rebuttal. We have given you an opportunity. The discussion will bring out. We want both of you to bring out the plus and minus points of both of it. Dr. Anaga, I think amongst us is a square, means anti-segment surgeon who can highlight something.
Yeah, I'm an anterior segment cataract surgeon, so I would not be able to actually give in more inputs on this. But as I said in my previous thing also, I think first of all depends on what the patient presents with, and each situation is going to be unique and different. So depending on the patient's presentation at that point of time, I think that decision needs to be taken. And finally, each patient's surgical or treatment, the post-operative side effects, complications will be there in some way or the other. So we have to take a decision depending on that.
Dr. Deepak, you are any role in this debate? If you can add
Sir, since lots of residents are watching, so I would like from both the speaker, Shruti and Gunjan, which is easy to learn from your side.
Plication.
Out of 10 points, how much you give to your and how much to your opponent in terms of learning, easiness of learning.
See,
there's a learning curve for both, sir. So it's not easy because pushing the muscle under the loop is also a little tough, and actually getting the sutures on the right side is also tough. And of course, resection also has its own learning curve, I guess. So I would say equally both, but plication is less traumatic, at least for the residents and for the trainees to begin. Maybe Dr. Shreya is here. So
basically, it's a bloodless thing. Plication is something which is bloodless. Resection, as soon as you cut the muscle, there's a lot of bleeding, and unless you are using a cautery, you will have bleeding. So sometimes it becomes difficult for the residents to learn. Plication is easier to learn in that way. It's easier, and even if your muscle
slip of muscles.
Obviously, it's
chances of slip of muscle.
It's none with plication.
Yeah.
Okay.
Yeah.
Thank you.
I
So
think,
we,
yeah, we should move on to
we
the
can
next
move.
debate. And Prasanna,
Yes,
I want you to be a
we are yet to
timekeeper,
receive.
and you should be maintaining the time discipline. Okay?
Yes, there is a timer set up, sir. And we are yet to receive Dr. Ritika's file. So we'll move to the fifth set, sir, from
Okay.
pediatric ophthalmology to glaucoma. We have Dr. Karthikeyan Mahalingam for SLT versus Dr. Saiban Sethi for MIGS. Over to you, Dr. Karthik.
Thank ARC and YOSI for giving me the opportunity to speak. I'm going to talk about selective laser trabeculoplasty. It is just delivering laser energy to trabecular meshwork, which it spares the adjacent cells from and tissues from the thermal damage. In this image, you can see on the left side there is eye treated with organ laser trabeculoplasty. To SLT in the right side, the structure is easily preserved, so we can even repeat it again, and it provides similar IOP reduction. What do you need? You need a frequency double Nd:ARC laser and single lens. So if you want to do SLT, what you just need to learn to know how to do gonioscopy. Under topical anesthesia, you can place the gonio lens and visualize the angle. Using this following, you can start after focusing on the trabecular meshwork. You can see that red dot, and you can start firing the laser. You can go about 100 spots or 50 spots depending upon the angle treated. Easily, you can see the endpoint also. So performing SLT is very easy. It is an outpatient procedure compared to MIGS, which you need to learn the skill, and it is very costly in patients with primary open-angle glaucoma or ocular hypertension or secondary open-angle glaucoma. It has also been tried in normal tension glaucoma, in angle closure glaucoma also, wherever after PA. Difficulty in administrating medications, and who have difficulty in undergoing glaucoma surgery, and in pregnant women. So it's as I already said, it's a OPD procedure. It's very quick. It has less tissue damage and cost effective. Comparatively, all the MIGS procedure is usually performed along with a cataract surgery. So if you don't perform a cataract surgery, or if the patient is so do this selective laser trabeculoplasty, and it is cost effective also. All the device images will cost around 50,000 to 1,50,000. And if you risk of bleeding and post-operative IOP rise, etc. This SLT, it effectively reduces IOP in at least 75% of the patients, but 50% of the eyes might need retreatment at 2 years. This is the famous light trial which says that provides
network problem.
It's primary therapy or secondary therapy. It also not only in patients with primary, be effective in juvenile open angle glaucoma also, but efficacy is little less compared to primary open angle glaucoma. It has been tried in angle closure glaucoma also. Compared to MIGS, it is low effective method of reducing IOP in patients with primary open angle glaucoma. MIGS has if we go for MIGS, it has a inferior IOP lowering.
Karthik, can you summarize?
Certainly, in long term outcomes. Yeah, summary. SLT can be used as a primary therapy in open angle glaucoma and ocular hypertension. It's cost effective. It can postpone the surgery and reduce the load of glaucoma medication. It should management is performed. Even if it is less invasive, we usually go for the SLT. If failed, we always have the other option or modalities available. Thank you.
Thank you, Dr. Karthik. Can you stop sharing your screen? With that, we'll move to the next speaker, the counterpartner for MIGS, Dr. Saiban Sethi.
Yes, President. I'm just slides. Good evening, everybody. And thank you for having me here. I'm thrilled. And my part of the talk is going to be a debate on how minimally invasive glaucoma surgery or MIGS fits in glaucoma management. So essentially, for any procedure to have a future, it's very important for it to be effective, cost efficient, have longevity and real world data, and most importantly, safety. So without doubt, for any newly diagnosed glaucoma patient, medication is the first line of treatment. But for whatever reason, if the patient is suffering from side effects or non-compliance or is uncontrolled on maximum medical therapy, and this patient falls in the spectrum of mild to moderate open angle glaucoma, then you have two scenarios, whether to do SLT or whether to do MIGS. And that is where the debate comes from. So I will not disagree with Karthikeyan that if in a situation like this, the patient is phakic and doesn't have a cataract, then maybe SLT is actually a good option to go in for. But if in this same algorithm, if the patient has cataract, because a lot of our glaucoma patients come with concurrent cataract and they need IOP as well as cataract management, in such a situation, MIGS works beautifully with cataract surgery. Also, notwithstanding the fact that if these patients are advanced glaucomas, trabs and tubes are undoubtedly the only procedures to go in for. And time and again, various studies have shown us that a combined MIGS and phaco is much more effective in lowering intraocular pressure than phaco alone. And we have an array of mixed procedures available to us. So what SLT does is that it basically constricts the trabecular meshwork, and through the intertrabecular spaces, the aqueous goes out, which is very much the same principle that applies to MIGS, just that it does it a little better because you're removing the entire trabecular meshwork or bypassing it altogether. So the access of the aqueous is much better. And the future belongs to those who understand that we're entering an era of patient-centered care. So patients want procedures which are less traumatic, they have low frequent follow-ups, and also improve the quality of life of a patient, because there is no excuse for any patient to be looking like this, suffering from anti-glaucoma medications or inflammations. Mostly also when you compare head-to-head SLT with MIGS, I think SLT is very good for treatment-naive patients, which is not an area where MIGS is applicable to. I would suggest MIGS only when the patient also has a concurrent cataract. With SLT, it is a repetitive procedure. Almost 60% of your patients will need a repeat laser, and it is inconsistent. So you're more scared. You have to call the patient time and again to follow up to see when his IOP is rising, when you're introducing that new medication. In that regard, MIGS has a little more definitive role. And it is more definitive because we have long-term follow-ups of up to 7 years, which say that there were consistent 40% IOP reduction, 70% AGM reductions with these procedures. And also the factor of availability with SLT, but it's not like MIGS doesn't come with its own disadvantages. Of course, there is this problem of a big learning curve. The acquisition of the skill is something that we have to newly acquire. And like I said, SLT is probably best when used as first-line treatment, but for most other glaucomas which need further augmentation of treatment, I think a cataract surgery with MIGS is best. Also, understanding where it applies is very important. Even patients who have failed SLT have MIGS as an option, but vice versa is not possible. And you also have low-cost MIGS, as low as the cost of one needle or cost of one Prolene suture. So cost is basically not an argument that one should go in for in the MIGS scenario. In the end, I think for any glaucoma patient, we can argue all day about what is right, what is wrong, but the treatment protocol is very, very individualized. So it depends on what your surgeon knows how to do. If they don't know how to do mix, they will choose SLT. If they do, and there is no right or wrong, there is a place for all. Thank you.
Thank you, Dr. Saiban and Mahalingam, for putting their points in a proper way. But I am totally agree with Dr. Saiban that one thing which is important for any glaucoma case is the target pressure. So whatever the modality you know or you can have, you can do that and achieve the target pressure. That is the first one. And second, with as Dr. Saiban said, there is a slightly longer learning curve for the MIGS as compared to the SLT. But again, whether any technique is having longer learning curve or lesser learning curve doesn't matter. You have to learn whatever is the best, and both are in the market. And since as a glaucoma expert, most of them are using SLT. MIGS nowadays, Saiban is one who is using bulk, or you can say huge number of eye stent and other things. But still the younger ones need to learn both techniques. What I suggest that either laser is there or SLT or whatever the MIGS procedure is there. Those who are doing trap, which is the gold standard till date, can shift to MIGS because that is supposed to be a less traumatic. But again, it's the time or the future will tell how effectively or we can have anything which can replace trap. I don't know whether it is true or not. But still, we have to learn both the techniques. Prajanna, what you can say, because you are doing lot of things on the glaucoma.
I totally agree with you, sir. Mix as a learning curve. I would mostly prefer doing mix along with the combined surgery of cataract extraction, whereas SLT more of pseudophakic eyes would be my first preference in an OPD procedure again. So both has its role, and the learning curve, as you rightly pointed out, is slightly higher for MIGS, and there are many different types of MIGS which one needs to master. So along with stenting devices, we have the excision procedures, as Iban also rightly pointed out. And yes, sir.
So basically, very peaceful, no debate here.
Can I just add a point here?
Yes,
Can I
yes.
just add a point? Being myself an MIGS surgeon, I think SLT also I am using. But efficacy wise, as Saidaman ma'am said, there is a real world data problem with SLT in specifically in Indian population. That is going to be a problem. Efficacy wise, I don't know. Saiban ma'am, have you had any experience with SLT in your patients?
Ma'am, the only, to the best of my knowledge, I think the only long-term data that comes out of Indian eyes is actually like, I think done by Dr. Vinay Gupta. And it shows fairly good results. But this also, there is a specific category. So they tried SLT in treatment eye in patients less than 40. So that is not extrapolatable to the rest of the population. And also it's probably like, just like how we are as Indians not ready to accept, Western world data for our mixed cases. We are not advising them because we're waiting for our own Indian data. I think similarly, it's SLT is more dependent on ethnicity than MIGS is what I feel. And we need to have more robust evidence for both of these procedures, I feel. But again, it totally depends upon, the discussion between the surgeon and the patient. Are they looking for more definitive treatments? Are they looking for more conservative treatments? There is really no right or wrong over here. It's very, very patient individualistic.
And I think with regards to MIGS, we have more data rather than SLT, I feel.
Yes, I believe so. I think the longest Karthikeyan would have done his research. The longest SLT study is 10 years long. The longest mixed study is, I think, about 6 to 7 years long. But there is only one study which takes a follow-up of 10 years. Rest, most of them are about 5 years and less. Am I right, Karthikeyan?
I think, Dr. Saiban, there is no study on mix on more than 5 years on the Indian data.
नहीं,
Okay, most
Indian
of the
data कोई भी नहीं है. So there is no study.
that is
There
the
is now
issue.
this year we've seen GAT results and bank results, but those are only 1 year old data.
1 year.
Yeah. Apart from that,
Most of the Indian results are around 18 months or 24 months. They are one where places in few places where these studies are going on. But the published data is not of, I think, more than of 2 years on the Indian patient. But you said in the Western world, there is lot of publications or the things who can follow up for the 5 years or the 7 years. Okay, I think there is.
I'd like to interrupt here and let's move on because in view of time, we have more
Yes,
hot
yes.
happening.
Thank you.
And
Dr. Aditya, please invite next one.
we have Dr. Ritika. Her presentation is ready. I'll be playing it from here. Dr. Ritika, are you there?
Yes, sir, I'm there. I'm there.
So she'll be talking about SFIOL. I'll just share my screen.
I am very sorry for this hiccup. Yes, sir. So Iris, I'll very quickly summarize all of my presentation. Iris claw versus SFIL. So next slide, please. I would, having done both the procedures, I would always prefer SFIL over iris claw. So it can be done in any cases of aphakia, but it is an absolute indication where there is no iris tissue, is either due to aniridia of idiopathic cause or after trauma. It is preferable in pediatric age group, and it is preferable in other coexistent retinal pathology because of the issues of dilatation of pupil with the iris claw lens. Next slide, sir. So this is one paper which talked about that how SFIOLs are better than iris claw lens in pediatric age group because the dislocation of iris claw lens was more in pediatric age group. So there are a variety of IOLs that are available in the market for a 2-point fixation, for a 4-point fixation, making a Hoffman pocket, and we can also use premium IOLs and 3-piece IOLs to be implanted as SFIOLs. So where to implant is SFIL closely approximates the normal anatomic position of within the back IOL when entered 2 mm behind the limbus. So it is more in its natural position where a lens should be. So this is one small case. I always make a tunnel for SFIL so that there is no problem of bending of haptics. This case, I had to do a vitrectomy also because there was a IOL dislocation. So I had to do a full vitrectomy. Otherwise, in SFILs, it is sufficient that you do an anterior vitrectomy and clean your 3 and 9 o'clock hours very nicely. So I've made this tunnel, which is also made in iris claw lens. So this was the dislocated lens which I took out. So we can just quickly. I mark 3 o'clock and 9 o'clock positions, and then I mark 2 mm behind that mark, and then I take a 26 gauge needle, enter. This is the 3-piece IOL, 26 gauge needle. I enter it, making a scleral tunnel, and then enter at 3 o'clock. I also have a silicone tire to hold the lens so that it doesn't slip, so that the haptic doesn't slip inside. So we can move to the end of this video. So and then we cauterize little behind the thing. I actually cauterize the end of the haptics to form a bulb which easily goes inside the tunnel. I do it using Bobby cautery, and it has wonderful centration. So next is the dumbbell technique, which is basically used. This was a case of traumatic cataractus lens, and it is aphakia with total iris loss. So we made a tunnel, took a lens, and I use 5-O proline here. Yeah, so mark the opposite ends, mark 2 mm behind this. This is the analytic SFIL and 50 suture. Use Bobby Cotry to make a dumbbell so that it fits in the eyelids. Doing
Okay.
that on the both sides. And then just simply take out with the same needle technique and take it out. And just cautery the end so that it fits in the tunnel. So why SFIL? I always prefer SFIL as there is no ovalization of pupil. There is no problem of iris chaffing. And since there is no pigment release in this case, so there is no inflammation and no CME and glaucoma using this technique. Thank you.
Dr. Prashant, any comments on?
Srinivas, the man who does all types of fixation of IOLs.
Yeah, you're able to hear me?
Yes, yes.
Yeah. Hi. I think the interesting part here is both Aishwarya and Ritika were more towards showing so much of literature, so much of theory. I really liked it. Once you go on and you start practicing more of these things and stop looking into the literature, more of that. But to tell you, both of you very frankly, I have no this thing. Aishwarya did a fantastic job. She showed so much literature about the iris claw. I feel if you can not do a simple SFIOL with the pars plana technique, I suggest to do better going for the iris claw. That is the best way to do it. Rather than taking in for the SFIOL, either you do a dumbbell technique described by the Sergio Canabrava, or you do a Yamane technique, having that poking end and then causing a conjunctival erosion. The patient always complains of pain. You don't know what it is. Delayed onset endophthalmitis is a cause, is for the onset of all these things. So, suture degradation, as Aishwarya mentioned, yes, is a cause, was a cause. Because nowadays we don't use much of the sutures at all. So that's how the evolution has come into the 6O using the dumbbell technique or the Canabrava technique. The better is, I would like to say, if you want to put a suture, put the acryos with a 4 eyelet. Put a Gore-Tex. I think that is the best because we have not heard anything about the degradation of the Gore-Tex. Now, coming to the next point is iris atrophy. I have personally done 100 cases of iris claw and more than 200 to 300 cases of SFIOLs. I feel that iris claw, as a vitreoretinal surgeon point of view, they always prefer the SFIOL. So anterior segment surgeons more prefer the iris claw. It's more easier to do because if anything happens, it falls up into the vitreous cavity, which might be difficult to bring it back, or using the pars plana technique is the easiest way to do SFIOL. Second point, iris atrophy. Yes, I have seen cases happening because we have done a lot of videos on dangling iris claw lenses also. So if anything happens to that, then the only thing is you have to remove the lens completely and put it back. But whereas with the SFIOLs, if you see one haptic dangling, you can always refixate it through the vitreous cavity and bring it back. The second point is some patients do complain of shaky vision in cases of retropupillary fixated iris claw lenses. Third point is the pupillary peaking. Yes, it might be a momentary, but we do see some patients with a long-lasting pupillary peaking also in these cases. Third point, as you showed your video, it was very good where you showed there was a good dilatation of the pupil, but the replicability of that by the various other surgeons is not that easy. So the dilatation really becomes a difficult. If you want to perform any vitreoretinal surgeries, then it's really a challenge. For VR surgeons, especially if you want to do any VR technique, like if you want to put a gas or the silicone oil, there are more chances there are more chances that these might come up into the anterior chamber rather than with the iris with the SFIOL, which stays in the anatomical position. So I think both of you did a good job. But one thing I would like to say, what best suits your hand, please do it. If iris claw is easier rather than going ahead and manipulating more because everybody says that SFIOL is good, I want to do that, please don't do that. If it suits well, a fantastic retropupillary iris claw is always 100 times more better than a complicated SFIOL procedure. If you are a vitreoretinal surgeon or if you are an anterior segment surgeon having good experience to do an SFIOL either with the suture, 2-point fixation, 4-point fixation, Yamane's technique, modified Yamane's technique, Sergio Canabra, whatever technique, if you are good at it, if you know you can do it, then better go ahead and do a scleral fixated IOL.
I
Thank you.
think
That's my view.
that was typically from a vitreoretinal surgeon's perspective, which you echoed my feelings. But I think that will be going against the theme of the debate, the spirit of the debate. So let me have one opinion from an anterior segment surgeon. Anaga, you can definitely support the iris claw.
I would go in for an iris claw because I feel that it is very quick. And see, if you look at a condition where, suppose on table you have had a ZD or a significant PCR where you need to put in an IOL. So I would always prefer to put in iris claw rather than a SFIOL, which would probably take a little more time. These are surgeries which you do very, very infrequently. So it's not that you are doing so many cases, so you have to be very efficient, and the time is very important because already you've had a event on table, you are doing vitrectomy and all that. Least damage and least trauma to the patient is probably the focus at that point of time.
So I think be it if it is on table, if it is not about aphakia rehabilitation as a secondary procedure, if it is as a intraoperative complication where you are trying to have an alternative, I would just tell the youngsters over here, doing a good primary anterior vitrectomy and seeing that none of the vitreous fibrils are in anterior chamber are equally important, be it a anterior chamber or a iris claw or a SFIOL. That's what the message should go down the thing. You always do not do a mechanical vitrectomy with a Caesar. Always use a nice vitreous cutter, and all anterior segment surgeons should have it in their armamentarium working vitreous vitrectomy machines as well as the working vitreous cutter. I think now we can move on with the next thing.
Yes, sir. Next we have Dr. Sunandini Bose and Dr. Gunjan. So we are moving back from glaucoma retina back to cataract, simple capsulorhexis and chopping, one of the very basic things. So we have manual versus automated. Manual versus laser assisted, to be precise. Dr. Gunjan and Dr. Sunandini. Over to Dr. Sunandini first.
Shall I go first?
Yeah, you are going first. Manual capsulorhexis and chopping.
Hello, everybody. I'm Dr. Sunandini Bose. I thank the YOSI and ARC team for giving me this opportunity today. So I would be speaking in favor of manual rexes and chop. And to start my talk, I would like to ask you that whether we should go for an old technique which is there in the market for the last 50 years, which is very old and reliable, and which we are very well versed with, or whether we should go for a new technique which is there in the market for the last 10 years, and we are not very well versed with it, and it is very expensive. Starting with the rexis, an ideal rexis should be continuous to prevent the rexis extension, circular for the proper IO centration, and it should be of a correct size of 4.5 to 5 mm for a 360-degree overlap. So there have been studies which has compared these two techniques, and over here you can see that the overlap rate as well as the risk of anterior capsular tear was very low or practically insignificant in both these cases, or statistically insignificant in both these cases. There have been the meta-analysis case, which is of 2,941 eyes, which showed the diameter as well as the anterior capsular tear was not statistically significant, although the circularity was little bit better in the flags. So I would like to just show you a few of my cases where I try to do my rexes. I follow the Purkinje image. I follow the anterior anterior capsular strength, see that, and whether I'm doing it following this two technique or whether I am doing a intermittent mature cataract, making a small rexis, and then after that I'm trying to decompress the bag after completing this with the help of irrigating cannula, and after that I will just finish my rexis after doing an routine capsulotomy. Or It is a small pupil case where we can just follow the Purkinje image and not see the diameter of the pupil and do it as we do in our routine cases. So do we really need our femto lasers for doing our capsulotomies for us? So moving on to CHOP, it should be why do we need a good CHOP? Is an equal division of nuclear mass. Why? Because we need a fast and smooth emulsification. We need an effective phaco time, which is less. We need a time saving and fast surgery. The next day the cornea should be clear, and we should have a less or minimal stress on the zonules. So this study showed the differences between the femto and the routine cases in soft and hard cataract. And as you can see in the result, that there was no statistical significance between the effective phaco time between the two groups in the soft and the hard cataract, although there was some statistical significant difference in the medium grade of cataract. Also, study have also shown like this, where they have compared the femtosecond laser and the routine phacoemulsification endothelial count. And here we can see at the end of the 4 weeks, we can see that the endothelial cell densities were better in the phacoemulsification group, or there was no statistical significance. These are my routine phacoemulsification cases, which sorry for the sound, which I do on my phaco machine. It depends on the type of cataract or the grade of cataract, whether I'm doing a simple divide and conquer, whether I'm doing a direct chop or a crater or chop. The key is to know your phaco machine very well. Key is to know your phaco parameters very well. Your hand should be stable. You should be comfortable with the machine, and the machine should be comfortable with you. And I do not want to waste my 10-15 minutes shifting the patient from a phaco suite to a operation theater. And I would rather do another case and make some money out of it. And with this, is phaco really cost effective? For me, it does not fit this character. And as this study also shows, that phaco is not cost effective, and because of the higher cost, it did not provide any additional benefit over routine phacoemulsification. There were studies which have shown that there were very high rate of complications in femto, such as anterior capsular tag, anterior capsular tears, unstable pupils, incomplete capsulotomy. So what we really need is a safe and reliable surgery, repeatability, good post-operative vision, time-saving surgery. It should fit in our physical space that we own. The machine and the consumable should be cost effective, and annual maintenance should also be cost effective. So does phaco really tick all these boxes for me? It does not. So I would go for the old is gold method. I will continue my manual phacoemulsification and the rexes, that how I perform it. Thanks a lot. I'm sorry for the glitch. I have some throat issues.
Thank you, Dr. Sunandini. We'll move to your counterpart with laser-assisted or other automated capsular X's and CHOP. Dr. Gunjan, can you start sharing your screen?
Yeah, please, Dr. Sunandini, can you stop sharing your screen?
Yeah, I'm just trying to do that. It's not happening. Just a minute. Stop sharing. Yeah.
Dr. Gunjan?
Yeah. Is it opening?
No.
Just a second. Just a second.
Yeah. Do you want to proceed with the next set for you to be ready?
Yeah. Just a second. I don't know why I'm not able to open it. I was able to see it.
You'll have to open it, minimize it, and then share.
Yeah. Just
Prashant, sir, shall we move to the next set, sir?
Yeah, I think so.
Yeah. So next set, before we move to Gunjan, I would request Dr. Amit and Dr. Madhavi to be ready with their talk on bowl type perimetry versus virtual reality perimetry.
What's the status for Saransh, Prasanna?
Sir, 8:30, sir. He's joining at 8:30. After this set, we'll be able to take it, sir. Sure. So I would request first Amit to go ahead with this portable VR perimetry, followed by Dr. Madhav. Over to you, Amit.
Thank you, Dr. Prasanna. Is my screen visible in full screen?
Yes, Amit, please go ahead. Yeah.
Thank you. Thank you. And without wasting any more time, I'm going to talk about virtual reality perimetry. And so I don't have any conflict of interest. And another thing I wanted to say that I have not used VR perimetry. I've taken a few demos and seen them in conferences, but here's my take on it. Before going into that detail, there are many terms that seem to be a little confusing. I just want to clarify this. There's, of course, the reality, the physical environment around us, and then there is an extended reality, which is XR. This encompasses three things. One is the augmented reality, mixed reality, and virtual reality. So augmented reality is basically the real world environment with superimposed digital objects like the filters that we use in our social media. Mixed reality is the real world environment with superimposed interactive digital objects. For example, you must have seen in the movie The Iron Man how he uses his mixed reality, and virtual reality, which is a fully immersive digitally rendered environment that may or may not replicate the real world, like in VR games and entertainment that we use. So this is not a new thing. Virtual reality was started with stereoscopes almost 200 years back, and then it has evolved to what we have now. So what was once a science fiction is now just literal virtual reality. I'm not going to go into too much details of the history, but like I said, it started almost 200 years back. What's a virtual reality perimetry? These are head-mounted devices to assess the patient's visual field in a portable and immersive manner. It allows an accurate visual field testing in a range of environments, improving both accessibility as well as convenience for both patients and clinicians. There are a lot of VR perimeters that are available right now. These are a few. I'm not again going to go into too much details of these, but these are almost 10, and many of them have active eye tracking. They are some of them are US FDA approved also, and the thresholding algorithms as well as the tests like 30-2, 24-2, 10-2. They're very similar to what we are used to in our day-to-day practice. So what's the advantage of VR over traditional perimeters? First is portability and flexibility. The portable VR perimeter is lightweight, can be used anywhere. So there's no need of dedicated room or space. The internal gyroscopic mechanisms can compensate for the user's head position. So the patient can perform this test in their preferred sitting position. It's more beneficial for home visits, remote care, community-based screenings also. Patient comfort and usability, it's more ergonomic. There's no chin rest that is required. Patient can sit comfortably, and patients with mobility issues or old age and those who are unable to sit for long durations can also do this. It's more cost effective because there is lower cost of equipment and maintenance. It's suitable for small clinics, optometry practices, low resource settings, as well as easier for telemedicines. And it's AI integrated data sharing for teleophthalmology is possible. Cloud storage of results, which is definitely not possible with the ball type or traditional perimeters. Clinical accuracy, there are multiple studies that have shown their accuracy is comparable to the traditional methods, and it's only going to improve with better algorithms and machine learning. We can also do other tests like color vision, visual acuity, contrast sensitivity, pupillometry, and extraocular movements. So to conclude, the VR perimeters offers a significant advantage in portability, cost effectiveness, and patient comfort. And it's ideal for clinics with space constraints, telemedicine, and patients with mobility issues. It's rapidly evolving technology, and AI integration and cloud-based data management is also there. Whereas the bowl type perimeter still remains the gold standard in well-established clinical accuracy. and it's widely accepted and trusted for glaucoma as well as neuro-ophthalmology. But the future, I feel that the VR perimeter is an emerging viable alternative, especially in teleophthalmology, but the traditional perimeters will continue to play a crucial role. So VR perimeters complement the traditional perimeters, expanding accessibility and patient convenience without compromising on diagnostic reliability. Thank you.
Thank you. Thank you, Dr. Amit. Dr. Madhavi.
Yeah, I'll just share my screen. Is my screen visible?
Yeah, it's visible,
Yes.
not in full screen.
How about now?
Yeah.
Good evening, one and all. So today I'll be speaking on bowel perimetry. So by doing a reality check on the virtual reality perimetry. So what we actually hope to achieve with perimetry is a set of glaucoma diagnosis actually relies on a set of longitudinal data. So the stability of the visual field testing platform is absolutely essential. Visual field testing being subjective has a significant variability. So the current bowel perimeter is actually, it was introduced as early as 1872. This picture shows the forerunner of the current bowl, which was introduced by Shirk. So the advantage being this has been available and in use for decades. So it has a robust and strong normative database, and the progression analysis software is strongly validated. And even the gaze tracking system is good in case of bowel perimetry. So when it comes to VR perimetry, the questions that most of us have is VR perimetry suitable to replace the bowel perimetry? If so, which one would you choose? And are we ready to take decisions based on this VR perimetry? So this is a review article which showed a systematic review of multiple VR perimeters. So sometimes rapid innovation can be a blessing or a curse. So this particular meta-analysis actually showed 64 studies, included 36 devices. So why so many devices came into the market in such a short time is because visual field perimeters are classified as class 1 medical devices. So they are exempt from the formal pre-market notification and FDA clearance, which is actually required for OCT imaging system. So in such a short span of time, there are a lot of VR perimeters that has come into the market. So this exhaustive list you can see. So the question comes, is it sensitive? Is it specific? Is it accurate? And how about the validity? So with multiple models, varying thresholding algorithms, the standardization becomes extremely difficult. And many of these VR perimeters in this study has shown lack of parity with the current gold standard. However, in bowel perimeter, with such a long extending data, the results are comparable to a significant degree, though may not be exactly identical to each other. And as we already said, there is a strong normative database in case of our bowel perimeter. So patient with spectacles is another problem. Some of the VR does allow spectacles to be worn underneath, while many don't allow. And if you are introducing a trial lens or a Fresnel prism that is already incorporated, this can actually introduce bias distortions and affect the results. Next, coming to the gaze tracking, this is the HFA3 model which shows a relay monitor for gaze tracking. So you can actually see the eye position in each point that is being tested. Many of the VR perimeters lack gaze or eye tracking, though the modern ones are coming up with good eye tracking. So next is the applicability. Most of these studies on VR perimeters are done in limited sample size. And apart from that, they have tested varying levels of glaucoma. Some tested only mild, while some tested moderate. And most of them have not been tested in severe glaucoma. And some of them have limited field of view, and most of them showed more false positive due to the limited range of luminescence when compared to the HFA. So next is this immersive environment, which can actually create more claustrophobia, and some of the patients may not be used to using the VR headsets. And apart from that, though it is useful in some patients, it the applicability is limited in patients with neck injury or musculoskeletal problems. So again, coming back to the same questions, is VR perimetry suitable to replace bowel perimetry? With the existing evidence, it is not yet able to replace the bowel perimeter. So if so, which one would you choose? With so many in the market, it still remains a ball of confusion. And are we ready to take decisions based on VR perimetry? Not yet. To conclude, VR perimetry is still an evolving technology, and bowel perimetry is the current gold standard. Thank you.
I think we should have two views, one from Dr. Deepak Mishra as a hardcore glaucoma consultant, and one from Dr. Srinivas Joshi, who has a multiple hospitals here and there, so he can think about the economic part of it. So before first, we should have from Deepak.
Sir, as you said, there are two things. One is whether we are using this for the screening or for the diagnosis. So whatever we are doing as a VR, it is a faster one, and most of the time nowadays it is used as a screening tools. Means if we don't have the standard one, Humphrey or the another one, these VR will be helpful for those. And even it is the fast. Many of these newer perimeters, they claim that it is a faster way too. But I still prefer the gold standard one. Before we start for screening for diagnosis, can go for these newer ones. One is also made by the Janna. Janna, you can tell about your perimeter.
Sir, the point is that it was in favor of VR for me was the economics part of it, sir. It is very portable as well as very economical, especially during COVID time. The VR headset really made a lot of difference in my practice because the nose was outside the chamber, whereas in a bowl type perimeter, the nose was inside the chamber, and we had very much difficulty in doing and sterilizing or disinfecting the bowl type perimeter. So that time we had a lot of patients with VR perimetry. And then another thing was the portability, sir. Arvind Pondy has come out with this paper called Uberization of Eye Care, where glaucoma diagnosis really made a lot of difference when we were able to reach out to the patients with the VR perimetry, which is never possible with the bowl type perimetry. And with the recent strategies like this strategy in ELISAR, no financial disclosure, but it is as equivalent or very similar to CETA or CETA fast. So screening as well as even for progression detection, it really helps a lot. And economics, reaching out to patients, and especially during COVID, especially with the mask that the patient used to wear, when they were sitting on the bowl type perimetry, they had this tendency to pull down the mask. But those things all made a difference in VR perimetry. But bowl type perimetry is the gold standard. So both has a role in the patients that we want to reach and the patients who come to us.
Yeah, exactly. I think both have a role. Both can complement each other. It's of course for the it's a debate, so we are putting one against the other. But I think it's a complementary thing. The other probably the ideal one would be where we can transfer the data from our Humphrey or our Octopus into a VR perimeter, and the reliability and as well as the patient database, the comparative normative database that the machine has to even improve. So a VR perimeter from Humphrey or Octopus would probably be an ideal one.
So I think, Amit, we had a clinician's outlook to it. Let us have a corporate outlook to it and have an opinion of Srinivas. If Srinivas is missing, we have another, our ARC member who is competing with Srinivas in number of branches which she is having. So Anaga can comment. How about it having at multiple centers? Can you afford a Humphrey at so many cases? Or are you looking at VRV?
No, I already have. So I have HFA at my main center for the last now 25 years.
Not main centers, n number of centers which you have.
All the other centers I have VR perimetry.
I'm asking a wrong corporate, yeah. I thought you would be sharing something like a poor man like me.
No, that is why it makes a lot of difference, especially for beginners. They want to have a setup, they want to include it. So that makes a lot of difference, especially in a place like Bombay where space constraint is there. Instead of not having a perimeter at all, it makes sense to at least start with this. And over time, they will have their own normative database, and definitely things are going to be better. Definitely, I agree. HFA is the gold standard.
Done. So I think Prakash,
We
Prasanna,
can
move ahead. And
Sir,
move.
can we have the next, sir, before we move to the Saransh and take Gunjan back?
yeah,
Thank you everyone.
because
Yeah.
Saran should be midway place so that we have some information which goes across.
Okay, maybe after the next set, we'll take Saransh. Yes, sir. So
Yes.
next we have Dr. Zain Khatib and Dr. Nikunj Tank. So Zain will be going on monofocal IOLs and Nikunj will be countering him with monofocal plus and EDOF.
Yeah, am I audible?
Yes, Zain, yeah.
Okay, screen is
Yes,
visible, right?
Yeah.
Yes.
Okay.
Zain, the timer has to be stopped from your side. There is some timer on your screen.
Yeah.
Yeah.
Okay.
Thank you.
Yeah, thank you. Thanks for the opportunity. So I have 4 minutes to defend monofocal IOLs. Okay, the IOLs which we have been using for so many years, I've got 4 minutes to defend it. So when Prasanna spoke to me, he told me that, I have a very difficult topic for you. You have to speak on monofocals. And I said, why is it difficult? So I think the whole mentality is, why are we putting monofocals today? But the question actually should be, why are we not putting monofocals today? Okay, so with respect to IOLs, there's a lot of half knowledge going around, which honestly is, much worse than, having no knowledge. You rather not have knowledge, put in a simple monofocal rather than putting something that, is, don't know about. So there are some blanket statements being thrown about here and there, which are extremely dangerous. Okay, the first blanket statement is all monofocals will be replaced by extended monofocals. So you have an extended monofocal which doesn't look different from the monofocal, and you think that it doesn't do much difference. But actually, this is a very dangerous statement. The blanket statement too, which usually comes from the pharma companies, is that you get N10, N8 minimum with these extended monofocal lenses, and you get very swayed by these sort of sentences. Again, a very dangerous statement. So why people are talking about extended monofocals is because of the extra depth of focus we are getting. But are they actually giving us that depth of focus? And are they giving us something with pure monofocals are not giving? Let's evaluate that. So most of the lenses that are extended depth of focus are based on spherical aberration. So, whenever you have the peripheral rays focusing in front of the central rays, you have positive spherical aberration, which gives depth of focus. Or if you have rays which are focusing behind the central rays, it's negative spherical aberration. So these two concepts of positive and negative spherical aberration are being used by two very important lens manufacturers, no financial interest. Rayner uses positive spherical aberration, whereas Technis Eyehance uses a negative spherical aberration. Now, if you look at the Ray 1 lens compared to a normal aspheric monofocal from the center to the 2 mm zone, you see the aspheric lens is going down slightly, but the Rayner is giving a slight bulge towards the 2 mm. So this is 0.15 microns of positive spherical aberration, whereas the Eyehance has a bulge in the center, which is, a negative spherical aberration at the center is more curved than the periphery. But the point is to see how different these are from your normal monofocal lenses. And why is the Eyehance more than the EMV, although they are giving same range, is because the Eyehance is actually competing against the human cornea. So if you look at along with the human cornea, the Ray 1 is working with the human corneal positive spherical aberration, whereas Eyehance is working against it. That's why Eyehance has to give more of a bulge. The point is, when we are talking about depth of focus, what are we missing? Okay, if you look at the depth of focus in this 0.6 micron spherical aberration, you can see that, at the extremes, there is extremely poor quality of vision. So testing of contrast sensitivity at different depths is really important. And two variables that are important to decide the visual outcome are the pupil size and the corneal spherical aberration of the human eye. And there is this device called NEMO, which I learned from by Dr. Gatinel, where you can put in the IOL, set the spherical aberration of the cornea and the pupil size and compare what happens. So I'll just show you in 2 mm pupil, Eyehance and Rayner, good depth of focus, good, modulation transfer function. But when you go to 3 and 4 mm, you see how much of variation comes in the refractive stability. And when you go to 4 and 5 mm, you see the modulation transfer function really goes down of these lenses. Similar for a lens like Vivity, where you see what a low modulation transfer function these lenses are giving at different spherical aberration, a lot of refractive instability also. As compared to monofocal lenses, which give you relatively much better modulation transfer function and give you that depth of focus as well. So just an example, a 55-year-old lady, she was implanted with Rayner lens. You can see her, she has a very high positive spherical aberration on the cornea, and she has a large pupil as well. Okay, why she was unhappy is because, because of the high spherical aberration, she had a low modulation transfer function because of the large pupil. And the other eye, which had a similar spherical aberration and pupil, we just put a single piece spherical lens, and she was much better, able to read as well, and was very happy for distance. So just to conclude, you cannot apply blanket rules for all IOLs. The same IOL may have different effects in different eyes. The corneal spherical aberration and pupil measurement is extremely important, and understanding IOL technology is important before implanting. The most important statement is, just because you're doing premium IOL practice, that doesn't mean you have to just go on implanting more premium lenses. You must know all the lens technology. So thank you.
Thank you, Zain. Nikunj, over to you to counter Dr. Zain.
Yeah, thank you, Prasanna, and I'll just start sharing my screen first. Yeah. So when Zain talks about optics, I think we all can listen to him for hours, and he does a very fantastic job. But for my presentation, just for the debates part, his more than 50% of slides were talking about monofocal plus lenses. So that itself shows that he uses a lot of them. So I'll be talking about monofocal plus and EDOF lenses. No financial interest in any of the topics and talks I'm going to share here. So this is the design of EDOF lens. We all know that how it has been designed, and that it has a surface transition zone 1, which actually stretches the wavefront, and then in the central elevation part, this is a model of VVT. No financial interest, but this is right now one of the premium VVT premium EDOF lens available. Many platforms are coming up with their EDOF platforms like Technics Pure C and J&J Lux Smart or something, Bosch & Lomb Lux Smart. So it has a technology which stretches the wavefront by having an elevated plateau of the 2.2 millimeter in size, and then central elevated zone which shifts the wavefront away, which utilizes almost all the light energy without losing contrast. And Zain has mentioned about the EMV lens, which is the monofocal plus. I use a lot of in a lot of my cases. So why do we need monofocal plus lenses? As the time has evolved, and our current geriatric patients also, they have very active lifestyle, and they want to have spectacle independence for distance, intermediate, and preferably for near as well. And that's why the trifocal lenses were have been brought into the market, but not all the cases are eligible for trifocal, or sometimes not all of them are having affordability for the trifocal. So that's where the monofocal plus and EDOF lenses come into play. So it's all about finding the right balance. The best way to use monofocal plus or an EDOF lens is planning a mini monovision type of blended vision for the patient. So where you target 0.5 diopter myopia for the non-dominant eye and the emmetropia for the dominant eye. In certain specific monofocal plus lenses, you can target to -1, like in J&J cases, I target -1 or 0.75, something like that. And when patient is implanted binocularly, they are almost happy with their vision in both the eyes. So this is the recent article by Basin sir. He's practicing in Madhya Pradesh only, and he has showed the patient satisfaction data of the EDOF lenses. In this particular article, they have talked about VVT and have got good results. So I'm sharing a case example. If this patient comes to you who has 64-year-old male, retired, uses phone and TV a lot, is diabetic, he had PXF in one eye, but not other eye is absolutely fine. He has a cylindrical power, but he wants spectacle independence. So will you implant a monofocal toric lens and tell him that just to wear your presbyopic glasses, but his wish is to not to wear them? Or will you go for a trifocal lens in such case where he's a diabetic, also has PXF on his anterior lens capsule? So this is where EDOF or a monofocal lens comes into play, and I went with the EDOF toric lens. This is the case of my own father. I operated him recently, and this post-operatively he had a N10 in the right eye and N8 in the left eye. Surprisingly, when I have checked his vision by myself, that he was binocularly reading N6 line also, which he was not able to read with either one of the eye close. That is how this EDOF lenses gives a binocular independence from the spectacles. What about not so routine cases? So patient with a history of RD or patient with a RK. So this is the case of RK where one eye was operated many years back and monofocal was implanted, but for the other eye, she wanted something better. So it was not a very bad cornea, not very flat cornea. And you can see the keratometry values are predictable. So I decided to go with the monofocal plus toric lens in this case, and patient received a very good post-operative outcome, and she was able to read N8, which was even surprise to us. And this is the post-operative slit-lamp video of the same patient, and the cornea was clear, and patient is very happy. And she has maintained that vision also at 6 months. I have a 6 months record of that patient. So it works well. I'm not saying that all post-RK cases you are supposed to implant monofocal lenses, but you can select few cases where you can implant. So in a post-RD case, there are certain challenges. This was the case where you can see a demarcation line just sparing the fovea. And this patient also wanted somewhat spectacle independence. You cannot go for a trifocal with such a retina. So obviously I decided to go with the mono. He has a cylindrical power. So we decided to go with the monofocal plus toric lens, and he regained 6/9 for distance from 636 and N/10 for near from N18, which was his pre-op vision. So monofocal or plus or EDOF lenses gives very good distant vision comparable to monofocal lenses, and they give extra intermediate and functional near vision. And if you go for a mini monovision concept, it gives almost spectacle independence, just like trifocal lenses. And it is an actually alternative to trifocals in demanding patients with a little bit of complex anatomy like post-RK, other surgery, retinal detachment surgery, and etc. So yes, monofocal lenses will always be there with us, but monofocal plus are not going to replace them. But in many cases where you would want to avoid trifocal lenses, these are the lenses which come into play rather than going directly to monofocal. Thank you so much.
Anaga, why don't you make a final comment on this? You are a boss in this.
Yeah, so excellent presentations by both. So today, as we stand today, monofocals have always been there. What our patients need today is something more. So ye dil mange more. So when you can give something, but you have to be also careful and counsel them how they can probably have some problems also. Like for example, you showed about VVT, but when the pupil comes down in these patients, they can have issues. So you have to see the pupil size also. You'll have to look at the present corneal aberrations also. So you have to see what is best for that patient in their setting. Both these lenses, monofocals, have always been good, but the extended depth of focus as well as the advanced monofocals today are giving us something extra. So in a patient where everything else fits into place, definitely one should go in for them and give the patients a little more for intermediate, counsel them that definitely they will need some reader. One more thing is, a lot of patients have come to me for second opinion where a VVT has been put and they have said that you will not need glasses at all. So it just because they are more premium than monofocal doesn't mean that you don't need glasses at all. So that also is an important factor.
I think that is a perspective from a private practitioner. I think we have Deepak Mishra, who is representing a medical college where economics definitely make a choice, means influence the decision of IOL. Deepak? Dr. Deepak?
There is traveling, sir, so I think he's missing.
Okay, let us sum it up now.
Yeah.
Then.
Let's move on to the next. I think the flag stock is remaining.
No, I think we will have Saransh and then last part of the debate.
Pranesh is ready, sir. Dr. Pranesh Balasubramanian.
Yeah, Pranesh, welcome.
Dr. Pranesh, over to you.
So this Saransh is basically to make all the private practitioners, people practicing in the periphery within 10 to 12 minutes, the gist of the lately published articles, which can influence the decision, means their way of practice or understanding of a disease. So it need not be much into statistics. Over to you, Pranesh.
Thank you so much, sir. I think my voice is audible.
Yes.
Perfect. Great. So thanks again for this wonderful opportunity. I'm sorry that I didn't join this wonderful debate session earlier. So I'm going to talk about something which is different from what my previous presenters, the stalwarts, my colleagues and friends were talking about, the preferred practice patterns, the recent advances when it comes to decision-making with patient care. This is slightly going off bit. This is decision making when it comes to how to train someone, how to teach someone, how to educate our trainees. So with that in mind, I also see that the topic of or the theme is we are trying to find new solutions for the old problems. I think there's going to be a trend in this talk. We will understand that for the old problems, the solutions have not always to be new. The solutions can be old, but often they have been overlooked. So to make it more relevant, let us understand how we can apply these principles of education or teaching in different scenarios. And I will focus more on how do we train someone better. So for the ease of understanding, I've split into three components. The principles, the practices, what we should have in mind even before we start training someone, during the actual training, and after we have trained them. So before even we train them as surgeons, as surgeon trainers, it's important for us to understand that we are training not kids. It's not pedagogy, but it is andragogy, or we are training or we are teaching adults. And knowledge says that there are these 6 assumptions what we have to have for adult learning principles. We can see that adults want to know the reasons for learning, and experience provides the basis for learning. Adults are interested what's most relevant to them. They don't care what we want to tell them. They want to hear what they need to hear. And they respond to internal motivation, not external. Again, this is not a new solution, but it is quite old, but often we are overlooking this. Gardner suggests these multiple intelligences that we always learn in different ways. Not all of us prefer watching videos. Some of us want to watch podcasts. Some of us want to actually do things out there. Maybe read some books and write a journal. This is one example which I have recently found. It's quite interesting. The reason being, all of us are auditory learners to some extent. As you can see in this is a fantastic application where with AI, I can create my own voice, and my voice is going to read this textbook.
The lens should not move much during grooving. Optimal grooving is achieved when the lens nearly does not move. This implicates that in hard nucleus, you have to increase the phaco power. If the lens still moves, then go full power, but slowly. If the lens still moves, then do not groove with the tip completely embedded in the nucleus.
So this is not me reciting this. This is the AI of my voice is reading this audiobook. It's a fantastic way. I often felt it remarkable because I can always listen to this textbook over and over again. So the first pearl is how effectively do we teach or train depends on how we learn in the first place. By understanding the principles of learning, we can make sure that we teach or train our students better. So during the training, what's important is that most often this is one question what many trainers raise. How can we train the students effectively in the theater? Because theater is not a clinical place. It's not a lecture. A lot of things that's is at stake. There's a lot of pressure on the shoulders of the surgeon to train. So it's important to understand these two zones. There is a learning zone and there is this performance zone. And we always have to operate on these two different zones. The learning zone is where we actually can experiment and make mistakes and operate with the mindset that we can afford to make any mistake. So there is low stakes, low risk. On the contrary, the performance zone is like dancing with the sharks around. We perform, we execute our skills in a high stakes atmosphere where we are being judged on our performance. So it's important to know our zones. The learning zone is the comfort zone, but the high stakes zone is going to be the performance zone. So by constantly reflecting what we have learned, by practicing on models, wet labs, and simulation, and by getting good feedback, we can easily make a transition from that learning zone to a performance zone. So in that way, the trainer, the trainee, and the patient all are happy. May not be the goat, but of course we can save the goat's eyes as well, thanks to this wonderful IC simulator. So the place where I'm training here, they always ask me to perform the simulator before I touch a patient. So I have to complete this many hours of simulator practice of at least 12 to 14 hours is mandatory. And I have to show them this PDF, which shows my progression. Only then, even though we have operated a lot back in India, outside India, we always rely on simulation being a gold standard for any beginners in cataract surgeries. It doesn't always have to be the simulator. So Dr. John Davis has given this wonderful way to practice surgeries, not just using the simulations and high-end equipments, but also with kitchen materials and food. The most important thing is, how do we give a feedback for our trainees? That's the key. Something which my trainer didn't do that, but I realized that there is a way to give feedback. That's what Pendleton says. First, I will ask my trainee, what do you think you went well? Then I will tell him what I thought went well. And then I will ask him, what do you think went wrong? And then I will ask, then I'll tell him what I thought went wrong. So by this ask, tell approach, we're able to give them a feedback which is easily palatable for the students. Professor Golnick, who's one of the founder chairmen of the Ophthalmology Foundation, came with this wonderful Oscar rubric, which does not only give a way to evaluate, but also teaches us the different steps in phacoemulsification. So please go through this Oscar rubric. It's a fantastic way to grade the trainees' progress in their cataract surgeries and beyond cataracts. They also have rubrics for glaucomas, strabismus, and many other surgeries as well. Coming to teaching in the clinic, I just want to give you one important principle that is called as 1 minute preceptor. A biggest challenge in teaching in a busy clinic like Aravind or LV Prasad or any institutes is that the time deficit. And 1 minute preceptor is a fantastic way to make sure maximum teaching happens within a minimum time. So remember this mnemonic C3RT. You have to give a commitment, ask the student, why do you think? What is your diagnosis? The second question is, why do you think that is the diagnosis? Then tell them what they did right and tell them what they did wrong or what they missed. And finally, give them a message to teach. So all this process happens in a minute, which is fantastic. And I practice this in my place where I teach my trainees or undergraduates. I follow this 1 minute preceptor. This is one of the feedback forms which I made for my students when I was in Aravind. And my students is going to grade how I taught them. By this feedback mechanism, I also improve as a teacher. So this is one of my feedback from the students. He says everyday discussion is really good. And she often says that the practical exposure is much more useful than typical classroom lectures. So that comes to the other pearl. How effectively we teach depends on how well we listen to our students, how well we listen to our trainees. So we have to teach, educate them, train them in a way which they want to learn. And finally is the classroom teaching. So in classroom teaching, it's important to understand that there are two modes we often switch, the authoritative mode and facilitative mode. Most of the times, the lecturers, the professors, the seniors, and even who finish their post-graduation, the consultants, they often stick to this authoritative phase where they inform, they just teach the students. But what's more important is you have to be facilitative as well. Give them a place to vent out their feelings, make sure that we are supportive and being a catalyst in their growth. Finally, just want to bring my most favorite slide. A medical teacher or an educator is not just an information provider. Most often, we often confine ourselves only into this part. He's more than that. A clinical teacher is more than an information provider. He's a role model. He's a facilitator. He assesses the curriculum. He plans the curriculum and he provides the best possible resources. Now, again, this is not something new. This was given by Professor Harder in 2000. So again, it's an old solution, but it is often overlooked. And to fulfill all these roles and to go the extra mile, the most important ingredient is the love for teaching. And if you have the passion for teaching, and if teaching is your tequila, it's a great way to end the evening. Cheers, my friends. Let's all teach to reach.
Thank you, Pranesh. Deepak Mishra, sir.
Very well.
Thank you, ma'am.
Very nice, Dr. Pranesh.
It's really full of energy, so that if anyone is not in the teaching, at least he or she can join the teaching.
Yes,
Good.
absolutely.
Lovely.
Thank you, sir.
So I think we are at the end of the today webinar.
No, I think this is still remaining. Can we
have 2 sets remaining, sir, still.
Okay.
2 sets and 1.5 is still remaining, sir.
So, Dr. Aditya, can you invite the next slot?
Dr. Karthiki and Dr. Samir.
Karthik is here?
Yes, boss. We are.
Yeah.
Hello. Hello, sir.
Good, good.
Yeah, Karthikeya, please go ahead.
Yes,
Who is
sir. Good evening, sir. My
evening.
flight got a little delayed, so I could not attend.
It's okay.
No
It's
problem.
okay. Welcome.
I'll start my talk.
Yes, yes.
Please.
Is my screen visible?
Yes, yes.
Yes.
Let's see.
Can you go to full screen, Dr. Karthikeya?
Yes, sir. Doing that.
Yeah. Okay.
Is it visual?
Yeah, perfect.
Yeah. So, good evening, everyone. Thanks, AIOS, ARC, and thanks Dr. Prasanna Srinivas, sir, my mentor who is here. I'll be talking on a debate of anterior vitrectomy with dedicated vitrectomy systems. I'll not talk much on the basics of this. I'll just be showing 3 cases on this and proving my point how it is advisable to do anterior vitrectomy with dedicated vitrectomy systems. So let's talk with the case scenarios. My first case was a 52-year-old female with true PPC, and there was a PCR post-Phaco. So it's a very fast-forwarded video to show how there was a PCR after Phaco. So there was a snap, and we noted that there is a PCR. So now at this point, I decided to do anterior vitrectomy from the limbal route only. And now my vitrectomy system, dedicated vitrectomy system, has a toggle on and off, which is helping me to clear the vitreous as well as cortex very easily. While it is very rarely to find the system in a Phaco machine where you can do toggle and on and off. Only in Centurion system there is INA cut mode where momentarily you get this mode, but it is not possible to get it very easily in other Phaco machines. So the clearing is very good with dedicated vitrectomy system, and you can even put IOL under hydro if you have done an excellent clearing of vitreous and cortex. So this was my case number 1. Case number 2 was a 59-year-old female with 3 months post cataract surgery operated elsewhere. There was early endothelial decompensation secondary to vitreous prolapse, and there was raised IOP. So this was the case. Again, I'm using dedicated vitrectomy system, but I just wanted to prove one more point here. So I'm doing vitrectomy of the vitreous prolapse which was there. And at this point, it kept coming. So when you're doing from the anterior route, even though you can see that my infusion cannula is directed towards the root of iris, but still the vitreous keeps coming. So I had to make pars plana port, and it is very convenient to do. It's not a difficult task for even for anterior segment surgeon to make a pars plana port and do a anterior vitrectomy like this. Now you see the pupil, how beautifully the pupil is getting rounded. And in the post-op, you can see the silence of the AC and the IOP is well under control and no endothelial decompensation post the surgery. And my last and final case is a firecracker injury in an 11-year-old male. There was full chamber hyphema, IVMP, and topical steroids we gave. Then we planned cataract surgery, CTR, and IOL. So this case, also again, the cutter-assisted cataract surgery was done. CTR was placed. Now, after putting, now you can see that a lot of PC fibrosis is there, for which I need to do anterior vitrectomy and also capsulectomy. So again, I'm making a pars plana port here, which is again very much convenient. Now at a very high cut rate, I'll be cutting, and note the stability of AC here. AC is not moving at all, and there is no further traction on the zonules when I'm doing anterior vitrectomy along with the pars plana capsulectomy. And this is the whole system becomes very stable when you are doing at a very high cut rate and the dedicated vitrectomy system. So my points here is that the vitrectomy system gives a very stable infusion. We just have to know how to put a pars plana port. Toggle on and off is there, which helps us in a better clearing of cortical matter and in a PCR. And pars plana PC, if you have to do a pars plana capsulectomy also in a case of trauma or ZD, always a high cut rate helps you a lot. And there will be always a low traction with a high cut rate, hence the enhanced safety and efficiency. Thank you so much.
Thank you, Dr.
I'll stop sharing.
Dr. Samir, are you ready to counter with your slides?
Yes, sir.
Yeah, over to you.
Are my slides visible, sir?
Yes, Samir, proceed.
Very good evening to one and all. I'll be speaking for anterior vitrectomy with phaco machines. So as we all know, cataract is the most common surgery performed worldwide, and phacoemulsification remains the most common surgical technique that is employed. So invariably, we have complications, and the incidence of vitreous loss in cataract surgeries is around 2%. So to ensure a safe visual outcome in such cases, a meticulous anterior vitrectomy is often warranted, which can be done either with phaco machines or dedicated posterior vitrectomy machines, which can be an either dedicated anterior vitrector or dedicated posterior segment vitrectors. So beginning with the topic which matters the most to us, which is money. So as we are already operating with a phaco machine and we don't need any extra cost, any expenditure for that, whereas dedicated vitrectomy systems, whether it's a posterior one or an anterior one, we have to spend an extra buck for its procurement. Then having a separate machine, we often have to pay for the AMCs, the annual maintenance contracts, which are very, very expensive. And we also need dedicated compatible vitrectors for the same. Now coming to the cut rate and the probe size. So the phaco machine, majority of the phaco machines have a cut rate of 4,000 to 5,000 cuts per minute. Why cut rate is important? Because it reduces the traction and the risk of a break. Whereas anterior vitrectors relatively have a very low cut rate of 900 to 3,000 CPM. When we come to posterior segment vitrectors, for example, Constellation, when we use an anterior cassette, the cut rate is limited to 5,000. Even if we use a combined or a posterior cassette, although it gives a cut rate of 20,000, that is actually not very much required for an anterior vitrectomy and is more useful when we are either doing base shaving or doing vitrectomy close to the retina. So coming to the time, usually a separate machine is usually either in a separate OT in an institution or is usually not ready. For a phaco machine, we just have to connect the vitrectomy probe, whereas for a dedicated vitrectomy system, we have to either shift or set up the machine, which will require the time. Moreover, the dedicated vitrectomy systems have pneumatic cutters, which require compressor to move the guillotine. As we need to connect the compressor, this will further require time for the priming for building up the vacuum, whereas phaco machine usually have both pneumatic and electric cutters. Now coming to patient awareness, since all these factors are going on and we'll convey to our staff to set up the machine and the time taken, this will probably make the patient aware that something has gone wrong and will further add to the patient anxiety. And coming to the different modes, so phaco has both cut IA and IA cut. The IA cut is important as it will avoid during cortex removal of lens matter once the rent has occurred, as it will avoid unwanted traction on the vitreous. So this is a video where a vitrectomy probe is being used for the removal of cortex, whereas such modes are not available in dedicated dedicated vitrectors. So one might argue that machines like consoles like Constellation also have phaco attachment to it. So why not use that as well? So the problem with doing a phaco with such a machine is that these machines usually have Venturi pumps. So these machines usually result in a rapid vacuum buildup and are usually unsafe and can result in complications such as PCI, whereas phaco machines have peristaltic pumps, and machines like Centurion have active fluidics, which result in a much more safer and a controlled surgery. So another point which Dr. Karthike was pointed out again and again was pars plana vitrectomy. So pars plana anterior vitrectomy is also possible with phaco machine 23 gauge trocar and cannula, and can be done by anterior segment surgeons as well. So coming to conclusion, the majority of us are anterior segment surgeons, and cataract is going to be our bread and butter. And most of us are going to have phaco machines. So considering the cost and the time and all the other factors, anterior vitrectomy with phaco machines remains the. Thank you.
So let's have a discussion. I think because Srinivas, it will be quite an Karthikeya's bias would be there if Srinivas comments on this particular case. Now I realize one thing, he is a VR surgeon. Second thing, Guru bhi hai uska, Karthikeya ka. So I think it would be a very biased discussion. So let me have it from Dr. Anaga.
So both have spoken extremely well. So there is absolutely, definitely, phaco surgeons are going to have the phaco machine with them when they are operating. So you should have directly using that in case of an event makes sense. But if you are having, you're also starting with the retina practice, you are having a retina colleague who is coming to you and then doing other surgeries. So you will have dedicated vitrectomy machine also. So it depends on when you are starting initially, you may not have so many retina surgical systems and like constellation and all. It becomes very financially.
Anaga, forget about it. Do you use a constellation machine in your OT, though you have a VR means VR surgeon visiting you, or you use a vitrectomy machine if you have a PCT, which is dedicated, means a phaco machine
I use a phaco machine only.
Okay. Deepak, you also have the privilege. What about you? In an institution.
Sir, I am the anterior segment surgeon. So usually use the vitrectomy available in the phaco, not doing the core vitrectomy or have the separate vitrectomy machine.
Now let's have a perspective of a VR surgeon who is also happens to be a guru of one of our debate here.
No. Thank you, Prashant sir. Hi, Karthikeya and Dr. Chaudhary. Both did a fantastic talk. But as you say, sir, whenever there is a term called as guru, then he always has to be unbiased. So I'll give my unbiased opinions here. So one thing is, yes, phaco with vitrectomy is definitely what I have seen in most of these conferences when we have this debate. Most of the anterior segment surgeon do not prefer to go to the pars plana route. Whatever said and done, they always have that in mind. They don't want to go to the pars plana route. However good the surgeons are, I have taken this opinion and they don't want to do that. So phaco with vitrectomy machines nowadays, good phaco, as Dr. Chaudhary said, are now coming up with 5,000 cut rate, better duty cycle, less traction on the retina, the vitreous, toggle between the vacuum, which was one thing which was lacking in the earlier machines like Infinity or with the Laureate and all those things. The basic what we were lacking is the vacuum. If you want to pull up the cortex, the remaining cortex, if you want to pull it up, then that was really a challenge, is because again you have to change it and go into the IA mode. But now with the recent phaco machines, especially the Centurion, they also have a toggle between the vacuum and the cut also, which is an added advantage. But as said, not everybody have affordability to go in for the Centurion machine like Anaga madam here with multiple centers. But some of them, when they are having a basic machine, then that becomes a problem. Now coming to what Dr. Karthikeya was telling, he's a very trained, a wonderful vitreoretinal surgeon. So he always can venture and go into the pars plana route, handle most of the complications, even if the CTR falls down, even if the cortical matter falls down, even if the nucleus falls down. But one thing we need to remember is it's always expensive. The cassette charges are much very higher now. And the reusability of the cassette is really a challenge nowadays. I had one example where one of the surgeon had a few cases of end-off, one case of end-off in that. And I asked him, was this anything you did differently? Then he said, I had not taken out my vitrectomy machine for many days. And there comes the question about the sterility, about whether they have ETO'd it, whether they have done that. So a standalone vitrectomy machine with a single surgeon is definitely a challenge. So it's always better to go with the phaco with the vitrectomy machines if they are a standalone surgeon.
If you are working in an institute, in a college, or in any of these things, then you always have a dedicated vitrectomy system. You always can pull it up and bring it to your OT and do the vitrectomy either in the anterior segment route or the pars plana route, whichever best suits your hand. But please make sure that the entire vitreous is removed, putting up a proper tramsin alone and checking up, including the entry ports, whatever is whenever there are vitreous. So doing a nice vitrectomy is more important here. I think these are the few points which goes in favor of both a dedicated vitrectomy machine versus phaco with vitrectomy. And the present day, the phaco with vitrectomy machines have an added advantage is because they have moved from 3,000 to 5,000 cut rate. And because of which I think the duty cycle, the safety, earlier it was 50-50, the duty cycle. Now that there are more better duty cycles available now with the better phaco machines. So I think both has its own advantage. Only thing is where you practice is more important and what you choose is more important.
Yeah, so very well summed up, Srinivas. You tried to be unbiased, but we could learn and understand. All could palpate your small soft corner for him. But I think the message which should go loud and clear is that complete vitrectomy is the goal whenever you're tackling, whenever you have a posterior capsular tear and a vitreous loss. Anterior vitrectomy can be done with a vitreous ports, whatever is available with a phaco machine in a dedicated, even in indigenous instruments. Please never do a mechanical vitrectomy and just put a lens and close the case. Please don't do it. Any mechanical vitrectomy cutter, because trust me, when we started our vitreoretinal procedures, we used to have a cut rate of only 600 cuts. So today, the phaco machines having a cut rate of 2,000, 5,000 is definitely a privilege. So with 800 cuts, if we could do a good job in those era, way back 20 years back, I think for an anterior segment surgeon, you should never get into a complex that you do not have a dedicated machine. You can definitely do a sufficient and an adequate vitrectomy with the available cutter. More importantly, in a such stressful moment, moving to another machine whose foot pedal is new to you and everything is new to you, you would create more of a complication even with the best of the machines. So be with your own machine and do it, and that should be the thing. That's what I think we can sum it up. What do you say, Srinivas? Is it okay as a VR surgeon?
Yeah, I'm actually batting for phaco with vitrectomy actually. Because dedicated vitrectomy, even the vitreous surgeons are only bleeding because of the higher cost of the cutter. So much expensive that the 20,000 cut rate has become so sky high, and the reusability in India is really a question where we want to have, especially when you have operated an endo or a HIV or HBsAg cases, you literally have to throw away that 28,000 in one single go.
Correct. So I think now let's move on to the next debate.
So
Last
we have
part.
Gunjan who has still not finished the counter for Dr. Sunandini. Dr. Gunjan?
Yeah. Can I share my slides?
Please.
Yeah, please.
Is it visible now?
Yeah, please proceed.
Okay. So thank you so much, ARC and YOSI, for giving me the opportunity to be present here. So I'm talking about femtosecond assisted rexes and chopping in cataracts. First of all, I have no financial disclosures. So why is it called femto laser assisted cataract surgery? See, the point is laser assisted. We are not talking about the complete surgery done by the laser. So we are in the era of using smart assistants in the workplaces as well. Also, we have a lot of voice assistants at our places, which are helping us in getting a lot of work done without any hassle. So if we are talking about manual versus automatic cars also, so a lot of people are still now going for automatic cars. We can understand the analogy behind it because it actually makes our lives easy. So once we talk about the manual capsular X's, it is said that even the artists of high calibers cannot also have very good same size circles when they are making these circles. So that also applies to capsular X's. So we can have all of the inadvertent events in these kind of surgeries. So now we are talking about the reliability of the surgery. So if we discuss about the capsulotomy, The dimensions and the size of capsulotomy are determinants in effective lens position, which in turn affects the postoperative refractive results. So nowadays, the cataract surgery is just not a cataract surgery for the patients in cities especially. They are actually going on towards the side of refractive surgery. So if there is an inadequate sizing, we can always have IOL tilt, decentrations, and increase posterior lens capsule opacifications. So precision, predictability, and reproducibility is very, very important. You can look at this diagram when we have this manual capsulorhexis with different kind of diameters. So if we have to buy a roti machine, then definitely we are heading towards the perfect results of these circular rotis. So if there's a 6-fold better IOL centration with femtosecond, why not buy this machine for your practice? So even if you look at these kind of asymmetric overlaps, it's very common in manual capsulorhexis. So better capsulorhexis gives a better effective lens position. A lot of studies have been done in the literature, and they all talk about better centrations with femto. Also, when we're talking about the femtorhexis edge smoothness, nowadays the machines are very advanced, and we do not have a lot of tears in such patients in such kind of cases. So definitely femto is going towards much better results. PCR also is very reported to be very less frequent with flax than with common conventional phacoemulsification, and also overall implications of the capsule-related complications have gone down in these kind of patients. Lens fragmentation also, if you look at, then you can see that there is a very easy pre-cutting of the nucleus that can help in decreasing the damage to the tissues, and inflammation is also decreased in such patients. You can look at these graphs also talking about the effective phaco time decrease. So in these kind of conditions, why not choose something which is very, very you are confident and you are saving your time, and also this is something this offers less complications and increases your safety limit in patients. So as I already talked about reduction of EPT with femto, there are a lot of comparison of clinical outcomes between flax and conventional phacoemulsification, and they have drawn that they have decreased interior chamber inflammation and corneal endothelial losses very less. So if we look at the new studies also, they are all discussing the new fragment patterns also have increased, EPT decreased EPT in these kind of patients. So also nowadays we're talking about the mental stress to the surgeons. So if we can have something which can, make our lives easy, why not use this kind of gadget in our practice to have, definitely it's not a gimmick. This is always helping you out in your long list of complicated surgeries. So inadequate pupillary dilatation also we can have femto with the use of lot of rings, and also this is so why not flax in these kind of conditions. And always we have to be on the new edge, that if we have something which is helpful to us in a lot of ways, why not use it? Thank you so much.
Dr. Anaga ma'am.
Yeah, nice talk, Dr. Gunjan. So I've been using flax for the past 6 to 8 years now. And believe me, there are times when flax is really good, like subluxated cataract, you can actually center the capsulotomy on the lens capsule instead of on the pupillary margin. If you have a cornea which is already, you have fuchs or a corneal gattata, then you know that your EPT, you can reduce by this. In dense brown cataracts, it helps because you have pre-cut nuclear fragments already. But in a mature, you should also know its limitations. In a mature cataract, it really doesn't penetrate into for the nucleotomy. You can still have tags because when you have a mature intumescent cataract, you have a plume of cortical fluid coming up, and that itself can prevent the femto from actually firing. If you have any corneal opacities, then that will prevent the femtosecond laser from doing its complete job. So it has its advantages and disadvantages. Definitely, it's a very expensive procedure. So if I don't think for a routine phaco surgeon, it can be more than 10 to 20% of their practice. So if you have the bandwidth of investing in it, you can offer it to your patients. But it's not definitely must have.
So do you mean, Anaga, not having it is a better option, or having it, we are missing out something by not having it, rather I should put it the other way?
For a beginner, definitely no. If you
No,
are
for
already
Divakant
established,
Mishra and myself, I'm asking.
you should also look at the paying capacity of the patients in your area. If they are ready to pay for a premium procedure like premium lenses, then why not? If a patient is ready to pay for a multifocal lens, then he can pay for a femtocataract also.
Am I and Dr. Divakant doing injustice to my patient by not doing a flax?
I won't say injustice. It's just you all are great phaco surgeons. So
Diva is laughing. What do you say, Diva?
Sir, I was laughing when
को भी पूछ लेंगे आदित्य के पास फ्लैक्स है भाई हम लोग कुछ नाराज हम गलत कर रहे हैं.
So I was laughing because ma'am said both of us are great phaco surgeons. Only sir is a great phaco surgeon. So I'm a retina surgeon. But yes, it's as I think what sir means to ask whether it's a necessary thing and we are doing injustice. I feel, sir, it's not. As ma'am has said, all of us are great surgeons. So it's just a fancy thing in my opinion.
Aditya has a flax, na? So he can also say.
Yeah.
No,
Aditya.
I don't have a flax yet, but yeah, it's a tool that I think we can all invest in the future with or currently. So it's an additional tool. I would say it has its advantages, like ma'am has rightly pointed out. Certain cases become much easier when you have flax with you. So it's
even
a
posterior polar cataracts, you increase the margin and it definitely gives you a good support. CCC is more perfect. So I've never
Representing
seen
a
a
YOSI
posterior
Young
capsular tear.
Ophthalmology Society Forum, you know, Anaga, that's why I asked you on behalf of them.
Yeah.
And I am also a YOSI member.
Yeah.
Like you veterans.
It's not a must have.
Okay, fine. So I think we had a wonderful discussion, wonderful debates. Young people and young Turks really
One
did
more
fantastic.
set is remaining.
Is there, sir?
So I think Srinivas, can I request you to thank this all young Turks for wonderful job they have done.
Sir,
Prashant,
one more.
one more set is remaining.
Oh, sorry.
One more set. Srinivas, sir, you want to call them, sir? You're on mute, sir.
You can call them, Prasanna.
Yeah, okay, ma'am. So the last set of the day, we have intravitreal injections by anterior segment surgeons. Speaker going to speak for it is Dr. Arutpriya, and against it is going to be Dr. Deepanshu. Yeah, over to you, Dr. Arutpriya.
Sir, am I audible?
I think best is at the last. This is a very important topic. So let's see how they both fight with each other. And it should be a real fight. Huh? We want to see it like a fight.
Okay. So when it comes to intravitreal injection, it's considered a gold standard method for drug delivery in many retinal conditions like wet AMD, diabetic retinopathy, vein occlusions, and so on. So these are mainly given by the retina specialists. So today I am here to advocate for the anterior segment surgeons why they can administer this injection. So once again, I welcome you all for the last debate of this session. So the first point in favor of them is their anterior segment surgeons are really highly skilled, well trained, and they have a profound complex knowledge of the entire eye anatomy. So when it comes to an intravitreal injections, it's within their skill set. So definitely they can go ahead and perform this procedure. So again, when it comes to the precision, they already deal with many complex procedures like corneal transplants, filtering surgeries, IOL exchange, and so on. So this intravitreal injections being a less invasive, again, they can perform this procedure without any hesitancy. Then when it comes to sterility part, definitely there's no doubt that they maintain an aseptic environment which starts from meticulous hand hygiene with the use of sterile instruments and appropriate draping. So definitely intravitreal injections will be safely given by them. Then when you want to expand the access to the patient's care, especially in the remote areas and where the require a timely treatment like endophthalmitis or any CME, and in places where there is a deficient retina surgeons, anterior segment surgeons can fill this gap for a timely intervention.
So this helps in comprehensive treatment to the patients without any referrals. And for the doctor side, they can expand their practice and they help in the retaining the patients. So the most important thing is overall there is a reduction in the patient's burden by decreasing their appointments and considering their financial burdens, and this reduces the travel time, and the most cumbersome procedure is the waiting time in the clinic. So overall, there will be a more streamlined care for the patients. So there will be then 100% satisfaction for the patient. So, however, there are some limitations for the anterior segment surgeon where they cannot combine these procedures, like they cannot combine with an orbit surgeries or squint surgeries or any infective procedures. So even the studies have shown that non-retina specialists can give the intravitreal injections by following all the safety measures. So I conclude that if an anterior segment surgeon is highly skilled, trained, and if he has a deeper knowledge about the disease and also the procedure, and if he has an enough resource and he anticipates the complications, he can perform this procedure. So beyond the debate, I would just want to add one thing, that in a setup where both the experts are there and if they work together, they can maximize the effect by giving for a comprehensive care for the patient. Thank you.
Okay, can we have the next talk, please?
Yes, sir.
Yeah, the last part.
After a lot of serious talks, this is probably the last of the lot. So Dr. Aruth has done a wonderful job. And disclaimer for my talk is no anterior segment surgeons were harmed in the making of this presentation. After that wonderful presentation by Dr. Aruth, she must have thought that she has thrashed her opponent. She has won the debate, but I would like to say, my dear opponent, the debate is still on. This is just the second half of it. So the topic given to me is intravitreal injections by anterior segment surgeon. I want to add another word to it. Why? Why? What's the need for it? When my opponent was very worried that there are less retina surgeons, I would like to say there are probably equal number of retina surgeons in my place as equal as cataract surgeon, or probably slightly lesser than that. So I don't think there is a scarcity for retina surgeons, and we cannot decide outcome of the event based on number of surgeons. So in order to defend my topic, I would like to divide this talk into two components. That is, one is technique, where if the person goes wrong, it can create a lot of mess, and certain conditions in which the injection is probably not required, that things are misjudged, and it's not indicated or probably contraindicated. So when we talk about the technique, however, it does not seem to be a rocket science, but things can go wrong at any step. The most common mistake one makes is intralenticular administration of the drug. That can be done probably by an inexperienced surgeon as well as an experienced VR surgeon as well. Apart from that, another important aspect is retinopathy of prematurity, wherein the technique is slightly tricky. One has to be very careful, otherwise you can end up in a medical legal lawsuit as well. So when we talk about the technique, these are few images which would make you realize that the primary surgeon probably thought that they would just do away with a small intravitreal injection of Ozurdex, but ended up implanting it into the lens, and patient ended up paying more for the cataract removal as well as removal of the injection as well as for the vitrectomy. Another important aspect of it is retinopathy of prematurity, wherein the space is very minimal. If you misjudge it by few like 0.5 or even less than that of mm, you can probably injure the lens and cause cataract or PC defect as depicted in this picture and reported in this literature. Apart from that, there can be injection given in suprachoroidal space, or people can, it can also cause retinal detachment. Now I would like to elaborate a few, show some conditions wherein probably the injection was not required and it was advised. So this was a 56-year-old female who was diagnosed as ITBRVO with cystoid macular edema. OCT was not done at the primary ophthalmologist clinic and was advised ranibizumab. So patient definitely came for another opinion. And when we did an OCT, to our surprise, there was no macular edema. So the final diagnosis still remains the same, ITBRVO, but the treatment has changed completely. We asked the patient to observe and did a thorough systemic evaluation.
Another interesting case of a 50-year-old male who had visual acuity of 6/36. As we can see, there is a well-defined pocket of fluid here, some subretinal lesion here. Patient was diagnosed to have CNVM, query PCV, and was advised anti-VEGF, aflibercept. When we did OCT thorough evaluation, there were multiple pockets of fluid with multiple PEDs and subfibrous materials. So after careful evaluation and assessing the patient, the diagnosis turned out to be fibrinous CSCR, and patient was asked to observe. Alas, at 3 months post-op observation, you can see the fluid pocket has completely resolved. Fovea is back to normal. Contour and PED is still persisted, but the subretinal fluid has completely resolved. Another interesting case where 40-year-old male with best corrected visual acuity of 6/24 with family history of diabetes had his primary presentation. He had blood sugars of 180, 90 with this kind of disc edema and hard exudates, intraretinal hemorrhages. Patient was diagnosed to be PDR with DME and was advised ranibizumab injection. But when we thoroughly evaluated the patient, the scenario was completely different. His BP was 270/136. USG abdomen was revealed that patient had chronic kidney disease. So final diagnosis was made of grade 4 hypertensive retinopathy. Patient was advised observation and systemic control. My last case in the paucity of time is of 44-year-old male. Patient was 2 months back was diagnosed to have CSR. When patient visited the primary ophthalmologist again, he was diagnosed again as non-resolving CSR and was advised bevacizumab injection. This was the OCT which patient had. But when we carefully evaluated the patient, as you can see, there was a clear demarcation line in the inferior retina, and this was a case of rhegmatogenous retinal detachment. And the primary surgeon had probably missed that peripheral retinal break. So the diagnosis as well as the treatment completely changed. So at the end, I would like to conclude by saying that fundus evaluation is must. Optical coherence tomography is an essential tool and probably we should be used. Clinical judgment is absolute necessary. You should not miss out on these peripheral findings or even the smaller findings which are there in these pictures. And I would like to say that leave it to the retina specialist. It is better to do that. I would like to acknowledge my friend Dr. Abhishek Singh. Thank you.
So I think we can have the poll from all the people who are attending, all the panelists. Should anterior segment surgeon inject or not? Srinivas?
Yes, he has to.
Hands
But
dikhao, yaar, hand
it's in
dikhao.
two things.
Let's have first the poll.
So we count you as VR surgeon.
Yeah, still. I need more.
Acha.
Fine. I think it's hands down for anterior segment surgeon. Tinku, you didn't say anything.
So all anterior segments are
Joshi, you didn't defend the VR group.
So you didn't defend the VR group, sir.
We had
No, no, Diva, let me tell it in this way. The board did fantastic job, but Arut and Dipanshu, see, I would vouch for anterior segment surgeon giving intravitreal injections in a case of endophthalmitis. They should know how to give the intravitreal injection, because it has happened in more cases, especially when the patients come from the remote areas or from the faraway places. Rather than keeping the patients observed, seeing them, putting the oral antibiotics, meropenem, imipenem, what all I have seen. But just a single intravitreal antibiotic injections could have probably saved those eyes, especially when you are not having a VR setup at your practice. Now, coming to the next point, Arut, anti-VEGF injections or a DEX implant given by an anterior segment surgeon just because he has an OCT, just because he sees that there is a cystoid space, just because they see that there is a subretinal fluid, then it's a tricky situation. If he is not trained, then it is something like a 7 blind men and an elephant. They will say it's a spear, it's a wall, it's a rope, it's a tree, it's a fan, but we should know that it's an elephant, right? So if the anterior segment surgeon is trained enough in the medical retina or has a previous history of the being a good vitreoretinal specialist, then there is nothing wrong in it. Nobody can control anybody's intelligence, yeah.
The anterior segment surgeon might be much good than a vitreoretinal surgeon also. But just because he has and vitreoretinal surgeon, he sees them giving the OCT just because he sees the cystoid spaces in the OCT and then try to venture, wo kyun de raha hai, maybe de sakta hu, usme kya hai? Being only an OCT specialist, then it's wrong. So that's where we have to judge between whether which kind of intravitreal injection belongs to, whether they're antibiotic injections, then yes for the anterior segment surgeon. Then if it's an antibiotic injection, if it's an anti-VEGF and a dexamethasone, then leave it to a trained VR person. Thank you.
Anything, Tinku? Dr. Tinku, you would like to comment? You're muted. You're muted. Dr. Tinku?
Yeah, Dr. Srinivas put it very well. Well, I think the technique is such, there's no rocket science, as one of the, the speakers said. So well-trained anterior segment surgeon can master the technique. And I think every anterior segment surgeon should know how to work in the pars plana space, especially when they're handling a case of endophthalmitis. They should know the technique of giving an intravitreal injection. But that said, it is not important. What is important is when to give the injection and not how to give the injection. So the anterior segment surgeon, of course, if he's well trained, it depends on the practice patterns, the location where he's practicing. If he's well trained enough to handle all these cases, he can go ahead. But then once you're giving the injection, you should, handle everything that comes with it. You should know how to handle the complications. And you should know how to follow up the patient. Like we've seen so many patients getting diabetics with TRD and then going into a crunch phenomenon. Patients with vitreous hemorrhage, you haven't checked whether there's a traction behind, and then those patients land up with worse vision. So I think every cataract surgeon should have the training to give intravitreal in the situation when required. But giving injections indiscriminately without proper training, I think that should not be done.
Okay.
That's good.
Sir, can I say one point, sir?
Nilesh.
Sir,
Nilesh.
because being a retina trained surgeon but practicing as comprehensive ophthalmologist, I would like to say that the day retina surgeons stopped doing phaco, the anterior segment surgeon will stop giving the intravitreal injections. That is on the lighter note, sir. But again, actually, what everyone is saying holds true. Like if you are because comprehensive ophthalmologist in a tier 3, tier 4 city, like in village area or a area is like family physician, they have to know everything and do something. At least some treatment has to be given and then send it to a proper place, because patients are not traveling even 50 kilometers to take an intravitreal injection. That is the problem.
Chalo. Great debates. I think Srinivas, time for us to.
Yeah. Thank you, everyone. I think fantastic debates, good set of talks. But last point, what Nilesh mentioned, I think Prasanna, Diva, Aditya, we should have had it in the debate whether the phaco should be done by an anterior segment surgeon or a VR surgeon. In that, you should have included Dr. Prashant Bhawankule. Right? He is the one VR surgeon who is doing most of the phacos. We do phacos only if it's a dual case where the cataract with VR intervention. But he does routinely cataract surgery also being. So next time we'll include this. At the outset, I would like to thank Dr. Prashant Bhawankule.
Alleging me. Past secretary of ISMSCS is alleging.
Whatever. I'm not discriminating between phaco and SICS now. But anyway, I would like to thank all the young pillars of India, the YOSI, the young blood of India, the young pillars of the Ophthalmic Society of India, headed by Diva and Nilesh. Aditya is there. A wonderful job done by Prasanna. Prasanna was, from 6:30, he's glued to the phone or the laptop, and very meticulously, I think he and Aditya have planned it. Hats off to you guys, all the speakers who have done such a nice, meticulous research study. I just loved it. We'll just record it and put it again in the YouTube ARC channel so that many people can refer it as and when the time permits. So thank you all my ARC colleagues, especially Dr. Deepak Mishra sir, who has always been the backbone, Dr. Anaga madam, Dr. Tinku Bali, who finally came in like an Indian police, finally made it.
though she was in her busy schedule, but still she made it. Thank you, madam. Thank you for joining us with us today.
Thank you so much. Lovely.
And
Lovely
thank you,
debate.
Prashant sir. Yeah. And
Great
thank you,
lecture.
Prashant sir. And finally, the Sunil from AIOS team and Tushar from ARC team who have been relentlessly working for all these webinars. Once again, wholeheartedly, thank you, everyone. Thank you, all the speakers.
Bye-bye. Good night.
Thank you.
The last photograph. Yeah.
Photograph. Anaga.
Yeah.
So 3, 2, 1. One more, sir. One more. 3, 2, 1. Yeah, done.
Chalo, bye-bye. Great job.
Good night.
Thank you. Thank you so much.
Good
Thank you,
night.
guys. Good night.
Good night.
Good night.
Good night.
Good night.